And then you liked a tweet that said thousands of free blacks owned black slaves in the antebellum South. And years after the Emancipation Proclamation in the United States, whites as well as blacks were still being bought and sold as slaves in in the Middle East. Do you want this agency serves our vulnerable black children who are over incarcerated, over entered into the systems of the state, and comments like that reflect a deep-rooted held belief.
And may I share that
You may absolutely
held belief with you, Senator? So that deep-rooted held belief is that each one of us, I am a man of deep faith, Christian faith, Bible-believing Christian. And as a result of that, it is my belief that we all descend from Adam and Eve, from the two humans who were created in chapter 1 of the book of Genesis. As a result of that, I believe that there is one race, and that is the human race. And I don't think we ought to separate people by race or skin color. I believe that everybody should be treated the same, should be cared for and loved and treated with respect and compassion. The tweet with regard to, I think it was a tweet you said with regard to whites and blacks being bought and sold, that was a true comment. So it was basically just affirming that that's an unfortunate truth.
So again, I appreciate your deeply held faith and your belief and that there is only the human race. Your position as the head of DHHS, an organization that is tasked with so many things that touch our healthcare industry, mm-hmm. and we in this state have a disproportionately high incidence of maternal morbidity
Absolutely.
And mortality
Yes,
for
ma'am.
Black women.
Yes, ma'am.
We cannot abide by that we're all the human race. That's not the reality of our healthcare system. We have to be able to acknowledge health disparities based on race. And
Right.
if you are refusing to acknowledge that race exists and that it impacts the healthcare industry, that is problematic is the nicest term I can come up with.
Senator Kavanaugh, may I respond to that?
Yes, please.
Okay, I think you are adding to my words. I did not say that there were not disparities, and I am aware that there are disparities. And we, in fact, when I was in Missouri, one of the, and that's the reality that I have to live in, is that there are disparities, unfortunately, based on skin color at times and in places. And we need to do what we can, and other qualities, by the way, are
But you are making comments that are harmful to people.
May I finish my comment?
Of another race. You're making comments that are harmful to people of another race in this platform, and then in this platform saying that you don't believe in acknowledging race, you believe in acknowledging the human race, but then you also believe in healthcare disparities. This is a very confusing train of thought to follow.
Senator, it's not confusing to me at all, and I apologize if it is confusing. We can continue to have the conversation to try to clarify it. What I was going to say is that in the Boot Heel of Missouri, which is down in the Mississippi Delta, which is a very poor area of Missouri, our rate of infant mortality and maternal mortality, but specifically infant mortality, in the Black population was higher than across the rest of the state. Obviously, that's the reality is that there aren't a lot of people in the culture that think about race in terms of just the human race, but they think of it in terms of breaking it up based on identifying characteristics. That's a reality that I have to work with as a leader. And I think my history demonstrates that I have done that. We work to improve those rates. In fact, we put a lot of focus into our poorer Black areas in an effort to improve the infant mortality rates as well as maternal mortality. I could give you names of people that obviously doesn't make sense, but I could give you names of people that we worked on those issues with. In addition, I would point to work that the current regional director for HHS, Joe Palm, that Joe and I worked on down in St. Louis. What we were aware of was that at the time, St. Louis was one of the 10 most dangerous cities in the United States, specifically for gun violence. Most of that gun violence was male, and it was Black on Black gun violence. We worked with the city of St. Louis, with many different organizations, and put together and by the way, there was also the issue of not just homicide and gun violence, but there was, we were losing 3 people per day due to the opioid epidemic, and many of those were in Black St. Louis. We put together the Opioid and Homicide Response Task Force and spent great deals of time in the poorer parts of St. Louis working to reduce gun violence among Black youth, typically being about 14 to probably 28 or 30 years old, and also opioid use. So I think my history demonstrates that although I see one race, the human race, that I am aware of disparities and actively work to eradicate those.
Okay. You liked a tweet that said, "How in the world can you be a Democrat and vote Democrat? This breaking news should make every Democrat ashamed and embarrassed of how godless their worldview is."
I don't recall what that tweet was in reference to. I don't.
Regardless of what it's in reference to, what it says is not something that's in the spirit of the nonpartisan Nebraska Legislature. Do you want to comment to those of us that are Democrats sitting on this committee? Is my worldview godless in your view?
I think there are parts, and I think there are parts of there are probably parts of the other side of the aisle that are as well, ma'am.
You think that I'm godless?
I did not say that.
Do you think that I'm godless?
I have no idea. That's between you and your God, as my religion is between me and mine.
Thank you.
Yes, ma'am.
That is something we definitely agree on.
Absolutely.
Abortion isn't healthcare because pregnancy isn't a disease.
That's correct.
Abortion is healthcare.
Senator, we're going to have to agree to disagree on that.
I think that even the most conservative women in this room and in this world will disagree with you, because a miscarriage is an abortion. And if you need to have an abortion because your baby has died inside of you, that is in fact healthcare. Whether you agree with abortion that is not for that reason or not, abortion is healthcare. Period. And you want to be the head of the Department of Health and Human Services, and you do not understand what is essential healthcare for reproductive health? I would not exist if abortion wasn't healthcare. Do you want to say anything further?
No, ma'am.
Okay.
There will.
Stand flat-footed and speak the truth on the issue of homosexuality. What is the truth of homosexuality?
So, Senator, the tweet that you're referring to was a tweet from Vodi Bakken, who is a well-respected Christian Black pastor, I might add.
Black people can be intolerant of gay people just the same as white people can.
I don't believe that I am intolerant of any people.
Then what is the truth?
Scripture is very clear about homosexuality, and that's what Vodi or Pastor Bakken was referring to.
So again, to be instilled as the head of the largest state agency that has employees that are part of the queer community, now we are going to make their boss someone who thinks that this is an issue.
So what I would say,
That would, to me, be a hostile work environment.
I would say that's an unfortunate interpretation, Senator. I would say, in response to your comments, I don't hear a question there.
Go
but
ahead.
In response to your comments, I would say that my religious beliefs are my religious beliefs, and yours are yours, and each other person's in here are theirs. My religious beliefs, in fact, throughout Scripture is, there are many commands that are given, 613 to be exact. And anytime we are engaged in something contrary to one of those, it's referenced as sin or lack of righteousness. However, please let me continue. However, one of the, and by the way, I would also point out that Scripture says very clearly in the book of Romans, I believe it is, in fact, I'm sure it is, says, for all have sinned and fallen short of the glory of God. That includes me, you, and everybody else in this room, according to the Bible. However, Jesus also said in a couple of different places, not the least of which is in Matthew, that the second greatest commandment is to love your neighbor as yourself. First greatest being to love God. So loving your neighbor is the standard. It doesn't matter what people do. I would go back to what I said before. It doesn't matter who people love. It doesn't matter what they look like. Every human being is created in the image of God and is to be treated with compassion, respect, love, dignity. And I want to ensure, I'm not here today going through the confirmation process as a missionary. I'm here today going through a confirmation process as a CEO. I want to ensure that every Nebraska citizen is receiving the best equal care or services that they can and that they need to ensure that they can succeed in the best possible way.
So when you have an employee who needs to take time off for their same-sex marriage, you will be just as kind and understanding of that request as anyone else.
Absolutely. Why would I not? Yes, ma'am.
Well, it's nice to have you say that, because your social media would lead people to believe that that might not be the case. And that is unfortunate. I have questions on another area pertaining to DHHS, but again, I would like to allow others to jump in if they feel necessary. Okay.
You can be done if you want to.
I could be, but I'm not. Do you need any more water, sir?
Senator Kevin, I'm fine for about 20 more minutes.
You can just nod to the pages. They are.
I would love a cup of decaf. Or
do we have any decaf?
I was going to joke and say, or a shot of whiskey, but I don't. but I don't drink.
That'll be for later.
Okay. Yes, ma'am.
Okay. Jumping back, there's this. I'm gonna have some levity for a moment, if you'll bear with me. There's a great.
I hope to find it funny with you.
There's this show that just came out that is a sort of a mocking show of NPR, and I can't remember what it's called now. It's puppets, and they're anyways the main character on it. Whenever he interviews and he wants to change topics, he does this thing goes boing boing. So we're gonna go from social media to YRTC Kearney.
Yes, ma'am.
Such a fun transition, right?
Yeah, you got. I think I'm looking forward to the conversation.
I don't know if you're looking forward to this or not.
It's probably going to be a tough conversation.
In 2023 or 2022, the legislature authorized appropriation of, I believe, approximately $20 million to renovate the facilities at YRTC Kearney, which is back to being an all-boys youth rehabilitation and treatment center. When Senator Day and I went to visit in November, because again, DHHS is in violation of the law by not allowing our inspector generals to inspect, we did a surprise site visit to get eyes on the kids that were there at that time. And at that time, the director, Mark Lebouchardier, who was very gracious and
Great.
took us around on a tour, did point out the facility that was supposed to be renovated. It had been gutted and sitting there empty. In the meantime, we still have youth sitting in a dormitory style that is possibly contributing to the staff assaults, because we are having youth that are in rival gangs put into a dorm together,
Yes, ma'am.
because that's what the facilities have available. And that is causing an increase in violence and an increase in safety issues for staff. What is the plan, and why has that building not been renovated and put to use?
So I appreciate that question a lot, Senator, and share your concerns. And by the way, I appreciate both of you going out to YRTC. That was shortly after I started. And I was pleased to hear that.
And your staff was very
Yep,
wonderful
that
and
they were
welcoming.
gracious, and
Yes.
I appreciate the legislative visit. You are welcome to visit other facilities as well. We would love to show you, obviously, what we can show you, which doesn't violate
Senator
federal
Reapy
law.
is dying to go on a tour of a few facilities with me.
Senator Reapy, I would be happy to take you with me.
I'll be a tag along.
Fantastic. I appreciate you, sir. So getting back to your question about the building, I think you said 20 million, but I think if I remember right, I could be wrong, but I
I
think it
could
was
be wrong.
15.6 million.
All right, we'll go with your number.
It's either 15.6 or 16.1. I think it's 15.6.
It was Senator Lowe's bill, so in full transparency,
And-
I don't know the exact.
And he mentioned it to me this morning.
I'm sure he
and I-
did.
He did, yes, ma'am, and I gave him a little bit of an update. So the building that actually, the way I understood it was that the unicameral wanted 2 buildings built and authorized or appropriated 15.6 million. Let's not.
We don't
use
have to
that
quibble
number,
over
but yeah.
millions.
Authorize some,
Today.
authorize some money and appropriation to get that done. Thank you so much. Is that cold? by the way?
No, it's hot.
Oh, it's coffee. It's fantastic. That's even better. Thank you so much. So for the money that was appropriated, we worked with a firm, went out to bid, worked with a firm to look at what we could do. And there are 2 questions on the table. One is the existing building being renovated, and the other is a new build or new construction. My understanding was that the unicameral wanted 2 buildings built for the 15.6 that would house, I believe it was 48 youth. To do 2 buildings was going to be well in excess of the money appropriated. In fact, it was I'm trying not to use numbers
That's fine.
because I don't remember the exacts, but I think it was almost twice as much as what was appropriated to do 2 buildings. However, so we said, okay, well, they didn't really stipulate that it had to be 2 buildings. They were really after, this was their intent.
Yeah.
They were after a certain number of units. So could we do this in a single building structure? So I can tell you that we have gone back to the I believe it's an architecture firm, as I recall, engineering firm, I'm not sure. And they have put together a design that we have at the department accepted, and that is in the process of being looked at. And I believe we're going to be moving ahead in the not too distant future, building a 48-bed unit. I think that's true. Now, with regard to and then it'll take about a year for construction, as I recall. What I don't recall is if that is exactly has been completely approved yet or not. But then I want to get to your other question, which was about the existing building being renovated. That building, it's been determined, was full of asbestos and numerous other, I think it had lead-based paint, as I recall, and asbestos, and had more than served its lifespan and needs to be torn down. The expense of actually refurbishing it or remodeling it would have been more significant than doing a new build. And it still would have had safety and code issues from its
Sure.
original HVAC issues and all
Yeah.
kinds of things.
I've seen the building.
Okay.
You
So
don't have to
so you
convince me.
understand.
Yeah. Okay.
Does that answer your question?
I think it does. I think it would be helpful for the committee, and I would rope Senator Lowe and Speaker Arch into this as well to get an update on the status of that. That is something that we have worked on the YRTCs, and I would add Senator Brandt as well, because he's been very involved in the YRTCs, but it would be helpful to get an update on the progress of that and where all of that stands, because it is concerning that we appropriated the money and it seems to have no action, but if there's action being taken, we'd like to know.
Yep, absolutely, and that's understandable. I understand, Senator, that there has been a bit of a history of distrust between the department or between the unicameral and the department, and I can assure you, we want to do everything we can to reverse that.
A great starting point would be more realistic fiscal notes that come into this committee, because this committee has had a long history of experience of death by fiscal note from DHHS. So that is something that I would put on your radar as a top priority for building goodwill with all members of the legislature, because the department has been equal opportunity death by fiscal note, I will say.
Senator, may I make a comment to that?
Sure.
If there is somebody behind me in the room from the department, I hope they wrote that down.
And also, if I might add,
Yeah.
always come opposed to every bill of Senator Kavanaugh's. She loves that.
I do. Yes. Yes.
May I ask one more question?
No, there's
I had to
neutral.
joke
Is this decaf?
It's
Yes.
neutral.
He comes in opposed to my bills, even though he's sitting as the chair. I am almost to the end.
Yeah, you can go.
So the tab that everyone has, that's ECON. This is the Economic Assistance Department,
Yes,
and
pretty proud of this, and I hope you will be too.
I'm sorry.
I said I'm pretty proud of this, and I hope you will be too.
My question is.
Economic Assistance Office.
Yes, so it is listed as a division. On your org chart, it has division directors, and Shannon Rotarian is listed as a division director. And she is listed as the director of the Office of Economic Assistance. My question / concern is, have you created a new division in DHHS? Because it seems to be that is what has happened. If you have, perhaps you are not aware, but I'm going to make you aware now that it is actually in statute what the divisions are, and that would require a statutory change. So.
I am aware. Yes,
Okay.
ma'am. So I see that it is under division directors. I think this is what you're referring to, ma'am, with the, yep. So if you'll look in the box, you'll see that it says Director of the Office of Economic Assistance. It is not a division, nor, in fact, I was unaware that it was listed under division directors, and that needs to be moved somewhere else, administrative leadership or something. But
And also on your website where the divisions are, it is listed as a division
Okay, we
where
need to correct that
it used to be, I believe, within,
CFS.
yes.
Yes,
So, okay, thank you. That was an easy one.
and
That was
may
a softball.
May I add a
Yes.
few comments to that?
Please
for you?
do.
Yeah, so we intentionally created the Office of Economic Assistance and pulled that out of Children and Family Services. As you can imagine, Senator, Children and Family Services is about protecting the protection and safety of children and families. And when children are hurt, that gets lots of attention and resources, as well as the Juvenile Services portion of Children and Family Services Division. Our concern was that the Office of Economic Assistance, that those assistance programs, I forget the number, I'm not going to use a number, but there are a considerable number, well in excess of 15 programs, TANF and SNAP and child support enforcement and child care subsidies and LIHEAP, and the list goes on. Our concern was that being in CFS, that the economic assistance programs just probably weren't getting the love or attention that they needed. And so we have stood up, as recently as I believe it went live January 2nd, as I recall, stood up the Office of Economic Assistance, and we're kind of splitting that out from CFS so that reports directly to the CEO so that we can be paying attention to that. I will go so far as to tell you that we are paying attention to that. And as recently as yesterday morning at 6:30, I was on the phone with the regional director for food and nutrition services for the USDA, talking about Nebraska error rates.
Mhm.
Yes, ma'am.
Thank you.
Yes, ma'am.
Okay. The OIG.
Yes, ma'am. Which
I've
hope I-
I've directly alluded to it. I wouldn't say alluded. I've directly stated the concerns about the Inspector General's office, specifically child welfare. You are in violation of the law. Period. You are choosing to remain in violation of the law. Why?
Senator, my response to that would be that we are following the state's attorney, which is the Attorney General.
But that is
We are-
that is an opinion. That is not the law. So you are taking a legal opinion over the actual law.
I understand what you're saying, Senator. I would say that we are following legal guidance from the state's attorney as the executive branch. And my understanding is that there is work in process that is occurring between this body, not this committee necessarily, but the unicameral, and the Attorney General's office and the administration to work out those issues in a way that works for everybody. I'm going to go back to, I want to also assure you that while we are adhering to the Attorney General's opinion, we continue to provide unredacted reports to the governor and the governor's office to ensure that.
But not to the legislature.
Well, let me finish, Senator.
Okay.
And we have provided, I heard you say that we have provided no information. I heard you say that in Dr. Bish's hearing, I guess. And that's technically not correct. We have provided some redacted reports to the legislature on things that we thought, or to the OIG's office, I'm sorry, to things that we thought they needed to be aware of in an effort to try to be transparent, even while this process is being worked through.
My office requested information that in November, that we have not received from DHHS pertaining to concerns within the YRTC.
So, Senator, I heard you. I appreciate you bringing that up a lot because I heard you say that with Dr. Bish, and as I was sitting there, I was thinking, "Gosh, I want to ask her what that was." I would love to find out what that was, and if it's information that we can release, we're happy to.
According to the Attorney General's opinion, it is the role of the legislature to provide oversight, and the crux of the argument is that we are delegating that authority to the Inspector General's office. So the fact that the Inspector General no longer has the access, but we still have the access, should mean that if I request something that the Inspector General previously requested, I should be able to have access to that.
So we are in this interesting dance, Senator Kavanaugh.
Where you are breaking the law, yes, go on.
I appreciate your perspective.
It's a fact.
And comment.
It is a fact, it's not a perspective.
We're in this interesting dance where all I can do is to assure you that I trust in the process and that the process is going to get resolved, and whatever information we can provide to you, I personally am happy to do that. We will do that for you. If we are advised by counsel that we cannot, I need to adhere to that. So I'm sure that resolution is going to be reached.
You are being advised by counsel, and you are taking the counsel that is advising you to break the law. Period. It's not my perspective. It is the fact. You are breaking the law. Whether the Inspector General issues an opinion or not does not change the fact that the law is what the law is. And until the law changes, you are breaking the law. That's the fact. And that is a concern. I think that might be possibly all of my questions. I would like to say one more thing that I was remiss in saying at the beginning, that I very much appreciate you coming here today, giving me your time, giving us your time. I also appreciate your service to this country
Oh, thank you.
and the history of service that you and your family have. I know that I was direct with you,
I appreciate directness.
and I appreciate you answering my questions. Obviously, I have severe reservations, but I just wanted to acknowledge that it is very kind of you to be so generous with your time today, and thank you for your service.
Senator, thank you. May I make comments in response? Senator, thank you. I appreciate your comment about generosity. My wife and I both frequently talk about generosity, and I hope that that is a quality, not just in time, but in effort and other resources that that I and she and I bring to the state of Nebraska. I know that there probably isn't I can't calm your reservations. I would imagine with some comments, I would like to go back to a comment that I made, and I would say that I think if you were to call anybody that I've worked with in the past in a number of different settings, they would say that Steve is characterized by kindness, generosity, love, compassion, will fight for the underdog all day long. And Senator, that is what I bring to Nebraska. I will fight for every Nebraska citizen.
Thank you very much.
Yes, ma'am.
Any other questions? All right. Seeing none, thank you very much.
Thank you, Mr. Chairman.
And so with that, we will take anybody who wishes to testify in support of Dr. Corsi's nomination. Is there anybody who wishes to testify in opposition? Is there anybody who wishes to testify in a neutral capacity? All right, that'll do it. So that will actually close our gubernatorial appointments for today.
Were there letters?
No. And then we will open up with the hearings on our bills for today. And I had 5 of them listed in order. And we'll start with LB 1178 and welcome Senator Wishart to open. Actually, let's do this. How about we just take a short break since it's been about almost 2 hours. So let's just take a break for about 5 minutes. We'll let Senator Wishart come down here and get started. And then we'll return here at around 3:15 and open up with 1178. Thank you. Okay, welcome back. So now, at that short break, we will open up with LB 1178 and welcome Senator Wishart to open. Welcome.
Well, good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Anna Wishart, Annawishart, and I represent the 27th District in West Lincoln and now Southwestern Lancaster County. And I'm here today to introduce LB 1178. LB 1178 is a bill that creates the Intergenerational Care Facility Incentive Grant Program to award one-time funding to eligible nursing facilities to establish on-site childcare. The total pilot grant program cost is capped at $300,000 one time with a maximum of $100,000 per applicant. And so I would consider this more of a pilot opportunity program. And the grant funding can be used for the following: modification of the nursing facility structure, modification of the nursing facility's outside campus space, purchase of childcare related equipment and supplies, and then any combination of such purposes. The grant program prioritizes eligible applications from nursing facilities located in rural communities as defined in section 81.1.228, disqualifies any facility that was cited for substandard quality of care during its most recent survey, and does not require the long-term care facility to also own or operate that child care service. So they would be able to collaborate with the child care service provider in the state to provide those services. The program also requires DHHS to work with nursing facilities and other stakeholders to review regulatory barriers that impede the development of an intergenerational facility and develop a plan for addressing burdensome regulations that do not impact the health and safety of the residents. I read about the concept of intergenerational care facilities in 2019 and was instantly inspired by the idea. Unfortunately, there aren't actually a lot of intergenerational care facilities around the United States, but what we're seeing on a global level, and even in the US where there are, is just incredible outcomes for both the seniors and the little kids, as you can imagine. I introduced this bill in 2020. It was at that time LB 1051, but the bill was stalled due to extenuating circumstances and the COVID issue as well. Just was not going to move this forward at that time. But I think a lot of us recognize that during that there was significant isolation among seniors in particular. And so again, this brought to light to me the opportunity for this shared space concept. So it is a simple concept: providing childcare in a nursing facility and creating opportunities for shared activities between seniors, citizens, and children. Providing these intergenerational experiences for Nebraska children and seniors epitomizes one of my favorite pieces of advice from Taylor Swift: never grow up. As many of you serving on this committee know, long-term care is struggling in our state, especially in rural communities. It seems like every week I hear about another nursing home closing or on the brink of bankruptcy. At the same time, I continue to hear from childcare advocates and parents across Nebraska that there's a need for more access to affordable and quality healthcare. Incentivizing the co-location of senior long-term care and childcare will benefit senior residents by providing vital social interactions with children, and will also benefit the children's social and personal development by having more adults in their life. And then on top of that, what we've seen from some of the programs that do exist here and then in the United States is a staff retention opportunity as well, because the staff who work in the nursing care facilities and long-term care facilities, often in challenging hours that are outside of a traditional 8 to 5, are able to have their kids in this care facility in this child care facility as well. And so they can stop over and see their kids while they're at work. Again, LB 1178 establishes a pilot grant program for nursing facilities to apply for up to $100,000 to assist in capital improvements such as renovating space and purchasing equipment for childcare. The total amount for the program is $300,000. So I just wanted to reiterate that one time. Ideally, we would see great success and participation in this program And also these pilots would allow for the department to work with them to see how do we just reduce some of the regulations that are getting in the way of these co-location of facilities. And then there may not need to be additional funding in the future because we've gotten rid of some of the barriers that are keep preventing these nursing home facilities from being able to collaborate with childcare facilities. So I like to see this as a way to test this out, see how it's working, and then hopefully I imagine it's going to be successful, and hopefully it's something that spreads across the state and we can be a leader in the country on this. Behind me will be testifiers from the long-term care industry, as well as a provider from North Platte who already has childcare co-located at their facility. Thank you. I would be happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Rippey.
Thank you, Chairman Anderson. Thank you for being here. And thank you for taking up this very good project. The question that I have, in your research, did you discover anything out of the Swedish model? I think for years they have been working with combinations of, I think maybe 20 years or so. And so it might be a real resource if you haven't already.
I have not looked at, I have looked at some models outside of the United States. I can't remember if it was the Swedish model, but definitely in Europe, you see more opportunities for different generations to engage with each other in these kind of intergenerational experiences. And then there's a wonderful study from Stanford University looking at the benefits of multi-generational time spent together and the importance of that in people's lives.
Sure. Another question for me. Have you looked at the opportunity for, if it's going to be kind of a pilot study of so many urban, so many rural, so many, to try to get an idea where it may work best or not work? Is that a consideration?
Yeah, when we considered this legislation, we actually wrote an incentive for a rural pilot, recognizing that some of the most challenged areas in our state in terms of assisted living and long-term care are in rural parts of our state, where I've heard about on appropriations, there are sometimes facilities where they have wings of their nursing facility that is unoccupied, and it could be an opportunity to change that into a childcare facility.
Would you accommodate if a for-profit wanted to go in this direction?
I would absolutely be open to that.
Okay. Thank you very much. Thank you, Mr. Chairman.
Yes. Senator Miller.
Thank you, Mr. Chairman. Thank you for being here, Senator Wishart. I'm sorry if I missed it in your opening. Did you say other states have already been doing this?
Yeah, some other states have not, I don't know to this level of incentivizing a pilot, but other states have intergenerational facilities that do exist. It's just when I was doing my research on this, there's not a lot in the United States, surprisingly, which is just surprising to me that there wouldn't be more childcare and senior living opportunities together. But I don't know of another program, and maybe somebody following me will know of some like actual policy programs that are incentivizing this.
Thank you. And then DHHS permits this. This is just establishing a grant program, correct?
Well, I don't think there is anything that prohibits this from existing now. It's just there are a lot of regulations around childcare and that come with costs in terms of building out a space that meets those regulations. And so this would help to kind of alleviate some of that for up to three facilities or more if they take less than 100,000. And then the goal is to have DHHS to request that they're working with these facilities to figure out what are additional ways we can reduce regulations so that sort of overhead capital expenditure is able to be reduced. And we can see more of these types of programs.
Yeah. Thank you for being here and thank you for your innovative approach. Appreciate it.
Senator Horton.
Do you know anything about shared fixed costs that might be saved? For example, if there is a food facility that both sides of the house could use, if there were medical that both sides of the house could use. I'm just guessing it might be a savings of 20% of those fixed costs, theoretically.
It could be. And I'm excited for the person in North Platte to talk with you because she or he may have some ideas on that.
State of Minnesota is one to look at. There might
Okay.
even be a builder up there who specializes in exactly these kinds of facilities,
Okay.
hypothetically.
Okay.
I will follow up with you after about that.
All right, so I'm assuming, and maybe somebody can answer this after you, there has been not much of a conflict with any rules, regulations around CMS.
Sarah Howard's here and she can talk more directly on that. But I don't anticipate there are going to be conflicts as long as there is, my understanding is, well, I'll let Sarah Howard talk about it. There's a few things that you have to do as a child care facility within a nursing home that you would need to abide by, but those are manageable.
She's chomping at the bit back
Yeah.
there to answer the question. So. Okay. Any other questions from the committee? All right, seeing none, are you going to stay to close?
I will.
All right, let's stay to close. All right, so with that, we will take our first testifier in support of LB 1178. Welcome.
Hello, good afternoon, everybody. Good afternoon, Chairman and members of the Health and Human Services Committee. My name is Jaylene Carpenter, JALENE CARPENTER. I am the President and CEO of Nebraska Healthcare Association. I am here today on behalf of our 401 nonprofit and proprietary skilled nursing facility and assisted living community members, and also here as a member of the Nebraska Chamber of Commerce and Industry. And we are here to testify in support of 1178. I would like to thank Senator Wishart for introducing this legislation and for her interest in promoting intergenerational care. We'd also like to thank former Chairman Howard for her continued support of this important project. Our members support LB 1178, which would establish the Intergenerational Care Facility Incentive Grant Program to provide one-time funding to eligible long-term care facilities to support startup costs associated with establishing on-site childcare. As the initial cost to construct appropriate indoor and outdoor childcare space, meet fire and life safety requirements, and purchase necessary equipment and supplies can be significant, this bill would help remove that barrier. We appreciate that the bill also asks the department to consider how its licensure and regulatory process providing childcare on-site at a facility might be streamlined without impacting safety. Nebraska Healthcare Association has multiple members who currently offer on-site childcare, and they all agree that while it's not revenue generating per se, the benefits of offering intergenerational care are immeasurable for everyone involved. Some of these intergenerational childcare facilities are at capacity, and while this bill addresses new childcare facilities, we would appreciate in the future consideration for this funding to also include expansion of existing intergenerational childcare facilities. Our members have noted the benefits that include sharing an environment for children and older adults, help children feel more comfortable in interacting with diverse populations. For our facilities residents, providing them with opportunities to interact with children on a regular basis can improve their mood and provide a sense of purpose. We also realize that having children experiences in nursing facilities or assisted living might encourage them to pursue a career in long-term care, which also is important. So on behalf of our members in the chamber and those that they serve, we applaud Senator Wishart's vision for growing intergenerational care. We're really grateful for the opportunity to support this effort. And we are here again in support and be happy to answer any questions.
Are there any questions from the chamber? Senator Harden.
Thanks for being here.
Yes.
Are you aware of any intangible benefits for older adults as they interact with children? What might they enjoy?
Oh, absolutely. From our providers who currently offer intergenerational care, there is both direct and indirect emotional support that happens. So directly, if they're assisting with any of the children in an activity, obviously there's a sense of purpose and support, but also even just passively, if they're able to look out their window and see children playing outside, that can also bring them joy. So there's a wealth of benefit that come to our residents by having children on campus, whether they're interacting with them directly or passively.
We live in a somewhat transient society. I wonder how many kids across Nebraska don't live anywhere near grandma and grandpa. who are in commercial childcare or childcare in general?
I don't have the numbers on that, but I'm sure it is many. I know me personally, my children did live near their grandparents until recently.
Thanks for being here.
Any other questions from the committee? Seeing none, thank you. Anybody else wishing to testify in support of LB 1178? Welcome.
Hi.
You may begin.
Hello, Chairman Hanson and members of the Health and Human Service Committee. Thank you for letting me testify today. My name is Holly Hill, HOLLYHILL. I am the owner and director of Trucks and Tiaras Intergenerational Academy in North Platte, Nebraska. First, I want to thank Senator Wishart for her support of early childhood education. Intergenerational childcare gives children strong, positive role models that they interact with daily. These interactions are vital for developing strong communication skills, a sense of community, and a positive attitude towards aging. Learning alongside seniors will help children see beyond their years in their own small worlds. They understand more about life and discover many similarities between themselves and their grand friends. This understanding and love lay out a foundation for celebrating diversity, a skill that they will use throughout their lives. Research also sees a marked improvement in later childhood development. In schools where older adults were an irregular fixture, children had more improved reading scores compared to their peers at other schools. Likewise, one study showed that when a child is mentored by an adult, they're 46% less likely to begin using illegal drugs, 27% less likely to use alcohol, and 52% less likely to skip school. I have been in childcare for 11 years. The first 9 years, I was a family childcare provider, and the last 2 years, I have been a center owner. I have always wanted to have a childcare center, but never could find anything that was exactly what I wanted. And purchasing an already existing, in October of 2021, I was approached about purchasing an already existing intergenerational center. The building in which the center was located was once the all-timer unit and held childhood memories of mine and my grandmother's. I spent most of every Sunday afternoon with my grandmother. Her favorite thing was to talk about babies. The room she called home for many, many years is what is now called Baby A. It is where our 6 weeks to 9 months olds are. So there's many signs that this was definitely meant to be. Our center sits on Linden properties. It's centered in the middle of Linden Estates, the assisted living program, and Linden Court, the nursing home and memory support, with a sidewalk access to each facility from our center. Being able to be a part of these intergenerational relationships has been so fulfilling. We enjoy going over for visits, whether it's making cards with the residents, having costume parties, or making a craft with them. In our partnership with Venator Properties, we have a low-cost rent. In return, we're able to give their employees a discounted rate in childcare. This partnership is not only between adults and the children, it's community-wide and helps our community in so many ways. With the funds that LB 1178, it could potentially help a program like ours add additional space, being able to have our friends from Linden come to our program and volunteer. Having additional space would also increase how many more employees and members of our community's children we can serve. Having access to more funding could also help purchase materials to help with the needs of both Linden residents and the children in the care of Trucks and Tiaras Intergenerational Academy. Anybody have any questions?
Thank you. Are there any questions from the committee? Yes, Senator Harden.
So it sounds like you are trucking the kids there. Is that how your model works? Or do the senior adults come to your center?
We go to each one of their centers
Okay.
or to their facilities.
Do you have an opinion in terms of which direction may work more ideally because there's probably going to be a lot of transitionary kinds of things that may happen here.
In the future, I would love to see that we were able to bring them into our facility.
I see.
I guess it's the big thing is what we have to do with dealing with DHHS and like background checks. And I mean, they can come into our facility as volunteers, but they can't really be that hands-on. So finding a way to get between that barrier, I guess, would be the best part.
A different lane of questioning. How much do kids benefit from story time?
A lot.
Can you unpack that for me? How much is a lot?
I would say that like research shows how much reading to children and the interaction that it comes with those elderly. It's very beneficial.
Do
I mean, it's one
teachers
of the
have
bigger
time to
things.
do lots and lots of stories throughout the day?
Do
Normally?
teachers?
Do teachers have lots and lots of time for
I
that?
can speak for my own teachers, and it's definitely something that I make sure happens a lot through our day.
I'll ask a different question. Would they have more time if perhaps someone else
Yes.
did more one-on-one?
Yes, absolutely. It would, I guess that is something that I saw in my dream world when I purchased the facility as something that we could bring those residents in. You know, COVID has really put a damper on, you know, like I said, I bought it in 2021, so it was right at the tail end of the big COVID thing, and we were still running into that. I mean, we had a big Christmas program planned for the residents. They had a COVID outbreak the day before, so it like dampened in those plans. But, you know, like getting around that, I mean,
Now, you mentioned a little bit ago that DHHS, and sometimes they rain on all of our parades. You were talking about hands-on. Would there be a conflict in the hands-on piece if senior adults were to have closer interaction with children as things currently stand when it would come to things like stories, early childhood literacy, that sort of thing? Do you have a perception on that?
as long as they're not left alone,
Not
like as
they're
long
not
as
left
they're,
alone.
you know,
long as
in
there's
a
a lead teacher
volunteer
in the
state.
room.
Yeah, as long as, I mean, because, I mean, you have multiple different like programs coming into our program. I mean, firefighters and police officers, and, you know, we have different people that come in all the time that aren't necessarily, you know, background checked for a child care center. So, I mean, having them come in as a volunteer isn't necessarily a big deal as long as they're not left alone.
Thank you.
Senator Repeat.
Thank you, Chairman Henson. Thank you for being here.
Thank you
You
for
came
having
in
me.
from North Platte. That's reflective that you have a real commitment to the concept of how seniors and infants can benefit one another. Now, what I gathered from, I think, your presentation, you're geographically remote. You're not on the same property.
We are on the same property.
You are on the same property. Are you building connected?
We are not. So the assisted living is on one side of us, and then there's a parking lot. And our facility is what was the memory support of Better Properties, but it is now connected with the nursing home that sits in the back of our property. So it's accessed through like a long sidewalk.
a side connected by a sidewalk, not by a walkway. As
Sidewalk,
such. Okay, so would that enhance the program if they were more closely physically integrated? Where the elderly people could, you know, hear the children, see the children, maybe more on a, not on a plan basis, but on an informal basis? I'm just,
Yeah, I mean, I could see that would be a great benefit, you know, I mean, in the ideal world that you could just build a
I'm just trying to look
facility,
at
yeah.
what would be if
Absolutely.
you had a model that you really wanted to try to test and
Mm-hmm.
say, and what's worked and what's, you know, literature search, what's worked and what not
Right.
worked. I'm just curious on that. But anyway, I appreciate you being here
Thank you.
and thank you for your commitment. Thank you, Chairman.
Now, one question since you're here. What's your thoughts on fingerprinting? Have you had any issues with that at all?
I'm gonna pose on that question. I mean, it's a lot better. I can really say that fingerprinting has been, the turnaround rate has completely increased on, I mean, a year ago, it was somewhere between 6 to 8, sometimes 3 months. now I don't see any longer than I would say 14 days. Sometimes the turnaround rate is within 24 hours.
Okay.
It's something I'm very pleased with.
Yes.
Yes.
That's-
As a childcare owner, it's a lot better.
It's a consistent thing I've heard among childcare owners.
I'm sure you have.
Yeah, so I'm always kind of curious how this process is going and see, we're always trying to make sure we do the best we can to make sure we're,
And we appreciate it. It's definitely helps us with staffing when we already are living in a world that's so hard to staff a facility like ours.
it's good to hear. Any other questions? Seeing none. Thank you for coming
Thank you for
testify.
having me.
Thank you. Anybody else wishing to testify in support?
Good afternoon, Chairman Hansen, members of the Health and Human Services Committee. Thank you for allowing me to testify today. My name is Kirsten Reed, that's spelled KIERSTINREED. I serve as the president and CEO for Leading Age Nebraska. Leading Age is a nonprofit membership association that focuses on providing education, advocacy, and collaboration among long-term care providers. I'd like to thank Senator Wishart for her support to address childcare challenges, as well as the challenges of our nursing homes and assisted living communities with this innovative solution. This important legislation provides an opportunity for long-term care communities to improve the lives of older adults that they support through meaningful connections, and will also support the bottom line of the use of their space to provide childcare. A study from the University of California, San Francisco found that 43% of seniors report feeling lonely. That correlates to 59% higher risk of decline in health and a 45% higher risk of death. Loneliness is not just an emotional condition, it's a health hazard. In recent years, we've become increasingly generationally segregated in our society. Participation in intergenerational programs and meaningful cross-age relationships has been shown to decrease social isolation and increase older adults' sense of belonging, self-esteem, well-being, while also improving their social and emotional skills of children. A study at Stanford showed that aging adults are one of the best groups to spend time with young children. Older adults are exceptionally suited to meet the needs because, in part, they are welcoming the meaningful, productive activities and they want the engagement. Intergenerational programming also allows adults with dementia to be able to teach children things that they still know how to do, such as folding a towel, categorizing items by color or shape that would normally be considered too meaningless for anyone else to do. Young children support older adults with dementia because they live in the moment. Children don't ask adults the tough questions that they're unable to answer that make them feel uncomfortable or insecure in everyday conversations. This grant opportunity allows assisted living and skilled nursing communities to complete the necessary preparations in order to have a child care center in their space. Facilities involved in this grant project are providing Medicaid and Medicare services. So the bill also covers the identification of statutes, rules, regulations, and other regulatory barriers, both on the child care side as well as the nursing home side, that may impede the development of the intergenerational facility model. Leading Age looks forward to participating in those discussions with DHHS and the recipients of these grants. As you will hear from other testifiers today, this does already exist in communities across Nebraska. However, we're sure that there are barriers that are in place that are preventing this from making it easier. Supporting our senior care communities to utilize their space for child care centers will make a significant difference in these communities by addressing important infrastructure for families and while ensuring quality care for older adults and children. Leading Age Nebraska appreciates the continued efforts of Senator Wishart to address this issue and make improvements to the proposed legislation to make it possible for seniors and children to have quality care. Thank you for the opportunity to testify today, and I'm happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Hart?
Can you comment on safeguards that might be helpful for the senior side? For example, would it be possible that an older person might reach down and try to scoop up a child and that darn back or that trick knee decides to show up at the wrong time? What kind of safeguards would need to be there both for the children as well as for the adults? What kind of things can we anticipate and make good decisions about on the front end of this?
Sure, that's a great question. I'm sure that the child care ratios would still need to be in place. So that's going to mean that there's going to be supervision for children as well as for those older adults that are receiving services, whether it's assisted living or skilled nursing services. There's going to be a level of supervision on both sides of this. The intergenerational programs that I've seen, Tabitha here in Lincoln used to have a program like this, and there were engagement of opportunities on both sides, and there were lots of safety nets. What we didn't see older adults that were in services going and, just scooping up a kid off the floor, those kinds of things. We didn't really see that happening. It was more the child care staff and the senior care staff working together to develop those collaborations of meaningful activities like the sorting shapes or those kinds of things that were going to be beneficial on both sides.
Great. Appreciate that. Thank you. Senator Rigby?
Thank you, Chairman. I had a quick question. I picked up a little bit. You said Tabitha had.
Yes.
I'm just curious, why did they walk away from it? Or did they?
Boy, it was set up as a model that was actually not connected to their nursing home. It was a day program. So it was a day program for adults that needed adult day support, as well as children that needed daycare. That model, I think the downfall of that was probably that the cost of providing those services was much higher than the reimbursement for
both
the
sides.
day service. Yeah. The childcare was always full and the day service was always having a lot of difficulty. So this is a little bit different because we're saying putting it in a nursing home or an assisted living
You have
program.
a captive audience.
What?
In a nursing home, you pretty much have a captive
You
audience.
do, yes. Yeah. And they're eager. They love when kids visit.
You're looking for some contact with the outside world.
We, back to Senator Hardin's point, we have become increasingly isolated and generationally isolated. Kids don't live next to their grandparents anymore. They don't get to spend weekends with them. So this is really meaningful on both sides.
I just was curious whether there was more to that story. When I heard the word "had," kind of
They did.
struck me a little bit. Thank
It
you.
was a beautiful program.
Thank you. Thank you. Thank you for being.
Thanks.
Seeing no other questions, thank you. And we'll take our next testifier in support of LB 1178.
Good afternoon, Chair Hansen and members of the Health and Human Services Committee. My name is Gina Ragland, Jinaragland. Here today testifying in support of LB 1178 on behalf of ARP Nebraska. We live in a society where care of young and old is increasingly segregated with very limited opportunity for the two age groups to interact. The epidemic of loneliness and social isolation among the aging isn't just an emotional travesty. It has been declared a global epidemic amongst the older population of adults by the U.S. Surgeon General. Studies show that regardless of where someone resides, isolation significantly increases a person's risk of premature death from all causes, a risk that may rival those of smoking, obesity, and physical inactivity. It's associated with a 50% increased risk of dementia, 29% increased risk of heart disease, 32% increased risk of stroke, as well as higher rates of depression, anxiety, and even suicide. Research shows that intergenerational shared sites increase the health and well-being of young and older participants. A recent Harris poll commissioned by Generations United and the Eisner Foundation poll found that nearly all Americans believe older adults and children have skills and talents to help one another, and that 85% would prefer a shared site that fosters intergenerational connection over an age-segregated facility if they or a loved one needed care. Workforce shortages and attracting and retaining quality staff continue to plague our state and the healthcare industry. Implementing these care sites that burden to lessen because employees can easily meet their own family caregiving needs by having a safe and reputable place for their children to go while they perform their work duties. Other benefits include greater job satisfaction among staff, improved recruitment and retention, and happier families of residents. Most importantly, consistent and regular staffing also trickles down to consistent and better quality care for residents residing in facilities. Aging adults are one of the best groups to spend time with young children, not only because they can pass down on decades of wisdom, but also because they are at a point in life when they can provide that stimulation that young children need to thrive. They seek and need purpose in their lives. Reading, singing, dancing, acting, playing games, and just plain person-to-person interaction. Not only are they stimulating their own brains, but they're also teaching and stimulating a young child's brain as well. Think about when a child touches the hand of someone who has been withdrawn and may no longer be verbalizing or speaking. That simple touch suddenly makes the person alive. There's something about having children on site which makes residents feel more human and gives them permission to care about others. It boosts their confidence and feelings of self-worth. It gives them something to look forward to. Many people with dementia thrive in this environment. When children are present, a physical change exists. Residents become more alert, smiling, present, and happy. Intergenerational connections may not be the only solution for loneliness and social isolation, but the evidence is vital. They not only help improve quality of life, but also help reduce the harmful effects of ageism. Participation in intergenerational programs may decrease social isolation and increase older adults' sense of belonging, reduced agitation, improved health, and overall increases in self-esteem and well-being. Children are the world's future, but that doesn't mean we should remit older generations to the past. The future of aging can be bright if we find ways to bring our oldest and youngest together for the betterment of our communities. It's not just a nice idea, it's necessary. Thank you to Senator Wishart for her ongoing work on this, as well as to Senator Howard for continuing to beat the drum. This is important legislation, and I do appreciate the opportunity to comment. We would encourage your support and the advancement of LB 1178 to general file. I would be happy to answer any questions.
All right, thank you. Are there any questions from the committee? Senator Reapy.
So I have one question. Thank you, Chairman. My question would be, is there any concern with the normal childhood diseases? I mean, kids get runny noses and everything else in terms of, I don't know how high risk elderly might, the connection there, whether that's
Yes, Senator, I think
how
that
dangerous that might be.
sure. I mean, I think that's the world we live in now. You walk into any
What, runny nose kids?
runny nose kids, yeah, you name it. No, I think just the spread of disease and that in general, but I know facilities do a very good job too about checking people at the door, if there is maybe an outbreak or something that's going on. Clearly, I think that the facilities do a good job of being cognizant about infection control. I think the same side on the facilities there. Obviously, if there's something going around, I know facilities close off visitation, that sort of thing.
Yeah.
I mean, I think we leave it up to them to make those choices and decisions. They do have infection protocols they have to follow, with CMS and that sort of thing too, as well as with the department. So I think it's a real concern, but I also think, again, that's the world we live in. And I do think facilities and childcare do the best that they can to protect not only the residents, but the public as well.
Okay. Thank you, Mr. Chairman.
Seeing no other questions, thank you very much. Take our next testifier to support. Welcome back.
This is my second to last time. I'll be super duper fast. I love seeing you guys. Okay. Chairman Hansen and members of the Health and Human Services Committee, thank you for allowing me to testify today. My name is Sarah Howard, spelled Sarahhoward, and I'm a policy advisor at First 5 Nebraska. First 5 Nebraska is a statewide public policy organization focused on promoting quality early care and learning opportunities for Nebraska's youngest children. My position at First 5 Nebraska is focused on the area of maternal and infant health policy, because we know that healthy moms and babies are critical to ensuring the long-term success of children in our state. I'm here to testify in support of LB 1178. And first, I want to thank Senator Wishart for bringing this bill. She's been really committed to innovative solutions to childcare. It's not just about subsidy. It's not just about money. It's about how do we innovate around childcare. And so that's what 1178 definitely does. I'm going to take some of us back to 2020. So 1051, Senator Wishart introduced this idea in 2020. And she introduced the bill on February 19th of 2020, and we went out of session on like March 11th or 12th. And so this committee actually didn't have the opportunity to send that bill out because we were just like working fast and furious. We knew something bad was happening. And then when we came back in August for that 3-week like turn it and burn it session, we were not kind of focused on some of these bills that are these lovely feel-good bills. I think 1178 makes you feel good. We were really focused on like YRTCs, COVID, a lot of other sort of major pieces. And so 1051 kind of fell by the wayside. So I was actually like super excited when Senator Wishart was like, yeah, let's do this one again. So I will just give you the stat that I think about a lot around childcare is that since 2019, we've lost about 12% of our childcares in the state of Nebraska, which is really critical because when you think about it, 3 out of 4 children in the state of Nebraska have both parents working. And so childcare is truly a workforce issue. Okay, with that, I'm going to try to answer some of your questions if I can. I was trying to keep track. I was taking notes. You saw me taking notes. Okay, I'm going to start with the licensure issue because I think that's kind of the crux of it. First off, I will say we already have intergenerational care facilities. You can see on the little handout, I made you a map. There are 9 of them. 3 of them I know for sure are actually housed in the same building. So that's Fairview and Fairmont, Imperial and Adams are all housed in the same building. Because at the core of it, an intergenerational care facility is about sharing those costs, the kitchen, the admin, you can share costs. And sharing those activities. So it's not necessarily we're on top of each other every day. It is that we are sharing space together and sharing those costs. So on the CMS side, there actually isn't a licensure issue. We because they are sort of separate facilities, they are licensed separately. They generally have to require a door that separates them. But as long as you have that clear door and that locked door, you are fine. On the childcare side, and similar to what Holly mentioned in North Platte, if they're going to be there every day, you're going to need to do that background check. And thank you for asking about background checks if you guys are curious. LB 898 was heard in the Judiciary Committee this afternoon. It's Senator Ibaugh's bill. It's a very nice bill if everybody's wanting to co-sponsor it. But the fingerprinting issue is one that's top of mind. But obviously, we wouldn't have the expectation that the members who live in the nursing homes or the assisted living facilities would be in the childcare facility every day and performing work. It's more about sharing that activity and that space together. Okay. There are 4 other states where there have been extensive studies around intergenerational care facilities. Senator Ballard, to your question, and that's Ohio, Wisconsin, Oregon, and Washington. So they've actually like encouraged their intergenerational care facilities and studied them. No other state that I know of has done like a grant program that's specifically like this one, which is we're going to help you with the startup costs. We're going to help you with the build out. And that's really what you need. If you're like, I'm going to put a childcare facility in a nursing home, the first barrier is that it looks like a nursing home, feels like a nursing home. We need to build it up to make it feel like a childcare facility. Put slides and an activity center outside. So the facilities piece, I think, is what makes this bill very, very unique. Background checks. I did it. Okay. The last thing I'll say, because I am a Swiftie, that I do hope that you will move this bill forward so that we can be in our intergenerational care era. There, I said it, and I'm happy to answer any questions that you might have for me.
Thank you. Too much Taylor Swift for me for one day.
It's twice. It's 2 times. It's just the right amount.
I'm going to get emails for that one.
Yeah, you are. It's very dangerous.
Okay, yes, Senator Kavanaugh.
Well, you just made my day with the Swiftie reference, so thank
You're
you.
welcome.
But not germane to this, but I just wanted to acknowledge that today we move forward LB 605, which former Senator Sarah Howard had brought forward numerous times to make art therapists licensed. And it was amazing. And it was Senator Albright's bill.
She did a really good job.
And it was a real labor of love. So it came to mind when you talked about the iterations of this bill and coming forward, and just wanted to thank you for your work on that, and to you and Senator Wishart for your work on this.
Yay, thank you. I was joking with somebody that art therapy is going to be able to vote. It's like such an old issue. Now you moved it, so it'll be fine. Awesome. Okay, Senator Hansen, sorry.
Maybe Taylor Swift will become an art therapist.
You never know. That's the third one. Fourth.
Yeah.
He's going to kick one of us
Any other
out.
questions for the committee? Thank you for coming.
Thank you for having me. One more time, and then I'm out of here.
All right. Anybody else wishing to testify in support of LB 1178? Anybody wishing to testify in opposition to LB 1178? Anybody wishing to testify in neutral capacity to LB 1178? Seeing none, we welcome back up Senator Wishart to close. And for the record, we did have, I'll get this right, 4 letters for the record, all in support.
Okay, well, thank you, Chairman Hansen and members of the committee. Just a couple things in closing. You know, when COVID did hit, I was particularly concerned about the senior living facilities in Lincoln and how isolated individuals were. And so actually my girlfriends and I took our horses, trailered them down, and rode around to all of the windows of some of the local nursing facilities to connect with the residents there. And we were met with people who were like brought to tears from having that connection, especially since they were so isolated at that point. And so I got a little glimpse of the opportunity that someone could have if they had so much more of the community, especially kids, engaged with them. I think it is so important for us as a society to slow down at the pace of individuals who are getting older and in facilities that keep them from being able to engage with the outside as much as they used to, because they do have a lot of knowledge and experience. And I talked to people that day through their windows, and they were veterans and people who had been married for 50 years, and just incredible things that kids should get an opportunity to be around. And so this is that opportunity for us to incentivize that. The second thing I'd say is I will work, and I've talked to Senator Hansen about this, I will work to find a way to look at some non-general funds, see if there's a way in our budget to be able to handle this startup cost one time without impacting general funds. So I'll try my hardest on appropriations to look and see if there's an opportunity for that, because I don't want the cost of this to get in the way of an opportunity for us to do this year.
All right. Thank you. Any other questions from the committee? Just make sure. Seeing none. Thank you very much. All right, that'll close our hearing for LB 1178. And we will open it up for LB 932 and welcome Senator Frederickson to open. Welcome.
You ready?
It's all yours.
All right. Good afternoon. Thank you, Chair Hansen and members of the Health and Human Services Committee. For the record, I am John Frederickson. That's spelled JOHNFREDRICKSON. I represent District 20, which is in Central West Omaha. I am happy to be here today to introduce LB 932. And I'm going to be honest, LB 932 is one of those bills where I feel like the last 72 hours have been very exciting. And we have new amendments and news to share on this. So stay tuned during this intro. There's a lot of information to share here. So LB 932 is a bill that the goal of it is to remove administrative delays for mental health practitioners to receive provisional licenses. This will allow them to move more quickly into our behavioral and mental health workforce. So specifically, LB 932 ensures that qualified applicants shall be provisionally licensed as a mental health practitioner upon application and payment of the fee. If the board finds that any provisional mental health practitioner has failed to comply with the qualifications set forth in statute for the provisional license, that license shall then be rescinded. A provisional mental health practitioner license shall transfer to a mental health practitioner license upon completion of the requirements described in section 38-2122 and shall expire upon receipt of licensure as a mental health practitioner or 5 years after the date of issuance, whichever comes first. So you may recall that this issue came up during the interim hearing on LR 202 that was before this committee this past fall. We heard that applicants had been waiting for as long as 6 months to get their provisional licenses. This is a big problem because these applicants are not able to practice until those provisional licensure is approved. Following the hearing, I met with DHHS and understood that there were 2 things that were contributing to this problem. One of the contributors was related to staff changes. The other was related to the expiration of an executive order that was issued by then Governor Pete Ricketts in early 2020 related to the pandemic. That executive order allowed for a more seamless process of provisional licensure during the pandemic, but that executive order expired in June of last year. So LB 932 sets forth provisions that would recreate processes that were in place during the pandemic and expedite the issuance of these provisional licenses. So this is where the tables turn a bit. So DHHS has since brought to my attention that they may have a better model for addressing this problem. There is a process that is currently in place that the department uses for dentists to help speed up the issuance of their provisional license. This process appears to be a good model for what we are attempting to achieve with mental health practitioners as well. In fact, the model can be applied to all professions under the Credentialing Act. This morning, I received potential amendment language from DHHS that would allow individuals in all of these professions, including mental health practitioners, to file their application up to 90 days prior to the applicant's graduation from the required course of study. I've handed out the marked up version that DHHS gave to us, which strikes my original language and adds their new language in another section. Other stakeholders my office has spoken with are also amenable to this potential solution to the problem. As I continue to work with the department and other stakeholders on final resolution, I would ask that this committee to hold off on any immediate advancing of this bill. I will be having an amendment drafted for this committee to consider. The conversations we have been productive, and I want to thank the department for working with us. It's clear to me that we all recognize the issues and all share the desire to get mental health practitioners and other professionals out into the workforce as soon as possible. As we compete with our neighboring states for workers, licensing processes need to be in place that incentivize people to stay and work in Nebraska, particularly in fields like mental and behavioral health, where there are workforce shortages throughout our state. In closing, as I said, I would ask that you hold the bill and allow me some time to work with the department to develop an amendment for this bill. With that, I am happy to answer any questions.
All right, thank you. Are there any questions from the committee? Oh, Senator Reapy.
Thank you, Chairman. I simply would like to compliment you, Senator. You've been relentless in terms of working to make this a bigger and better bill as it goes. And so,
Thank you. I appreciate it.
congratulations to you. Thank you.
Thank you.
Thank you, Chairman.
All right, seeing no other questions, are you going to stay and close?
I will be here to close.
All right, we will see you then. We'll take our first testifier in support of LB 932. Welcome.
Hello. Chairperson Hanson and members of the Health and Human Services Committee, my name is Lori Scharf, Lorischarff, and I am here today on behalf of the Nebraska Association of Behavioral Health Organizations. I am also a director at the Boys Town Residential Treatment Facility and a proud licensed mental health provider and social worker for nearly 20 years. We would like to start off by thanking Senator Frederickson for introducing LB 932, which will expedite the provisional mental health license process. In November 2022, the U.S. Department of Labor
launched Mental Health Matters, a national task force on workforce mental health policy. One of the principles addressed by that task force discusses the need to remove barriers to entry into the mental health and behavioral health workforce by identifying and addressing licensing challenges. For Nebraskans, LB 932 is our opportunity to do just this. Currently, to apply for a provisional mental health practitioner license, a person must have a master's or doctorate degree to include 300 hours of supervised direct client contact. Supervised hours in mental health practice includes the provision of treatment, assessment, and/or counseling to individuals, families, or groups for mental health treatment. The application requires an official transcript verifying the degree and coursework from an accredited program, such as the Council on Social Work Education, Council for Accreditation of Counseling and Related Educational Programs, or the American Psychological Association. This is not an all-inclusive list. A student must also submit an affidavit of their practicum that was completed as a part of their degree program. Said differently, it is no small feat to be qualified to apply for a provisional mental health license. Attending an accredited academic institution, supervision by a licensed mental health practitioner, transcripts, affidavits, practicums. That's a lot of checks and balances. With the high demand for mental health services, the need for mental health providers is higher than ever. The wait lists in both rural and urban areas continue to grow, so it is imperative that we find a way to decrease the wait time it takes for a qualified applicant to receive provisional license. This is a simple way to remove an unnecessary administrative barrier. As a supervisor of practicum students, I know the rigorous requirements necessary to successfully complete a mental health practicum. Doing things differently in 2024 and creating efficiency means being able to move a qualified student from an academic completion into immediate employment as a provisionally licensed provider. I'd like to end with a practical example. As a hiring manager, we estimate annualized turnover for our licensed providers. Based on this data, we developed paid practicums, which help build a pipeline of qualified applicants. We allow qualified applicants to apply for a clinical position prior to graduation, contingent on the completion of the required degree program. This on-the-job experience, matched with oversight by a licensed supervisor and accredited academic institution, provides sufficient, if not exceptional, information for a hiring manager to have confidence that the new hire is ready to perform the duties of a provisionally licensed provider. NABHO is very appreciative of the committee's time today, and we stand ready to improve Nebraska's healthcare. Thank you.
Thank you. Are there any questions from the committee? There are none.
Okay.
Thank you. We'll take our next testifier in support. Welcome.
Good afternoon. My name is Danette Novotny, DANETTENOVOTNY, and I work for Integrated Behavioral Health Services as a mental health therapist. I'm speaking on behalf of the Nebraska Association of Behavioral Health Organizations in support of LB 932. We thank Senator Frederickson for his leadership on this important issue. My education is in clinical mental health counseling, and I completed my graduate program requirements, including internship, in July of 2023. I was able to retrieve my transcripts and apply for licensure on August 15th, 2023. At that time, I submitted the application, educational requirements, internship requirements, and the fees required for review. From that time on, I was not given a time frame for receiving licensure and was told I would be notified if there was anything missing, any missing information, and or licensure approval via mailed letter. While my wait was timely, only 1 month, I have yet to receive a letter confirming my licensure approval. I found out by daily checking the DHHS website and did not receive a notification. I had peers who waited 45 to 90 days for their licensure or more. During the waiting period for licensure, I was unable to provide individual therapy or group therapy services for clients, affecting both my employment and clients who I worked with during my internship. I was lucky to have had an internship experience where I was offered a long-term position and they were willing to wait for my licensure. However, the interim time frame required other clinicians to offer counseling services, causing potential harm and turmoil for clients who I had built rapport with. Some of my peers were unable to obtain employment until after receiving their license. Having graduated from a CACREP accredited university, which stands for Council for Accreditation of Counseling and Related Educational Program, licensure should be able to obtain following graduation based on the high standards and expectations of the national education requirements and credibility of the program. If we can shorten the process by submitting the application and immediately able to go to work, the gap in services would have been shorter, offering access to services to those otherwise unable to maintain or receive counseling services, a benefit to both employers and clients in a field where there is a shortage of qualified clinicians. Regardless of where I have been able to maintain employment, my education or academia, work experience, and internship experience prepared me to be ready and qualified to work immediately through supervision, coaching, and work experience. My employer needed me to be ready to work. If the process was less lengthy, employers might be more willing to take a chance on internship and commit to future employment opportunities. Thank you for your attention, and I'll be happy to respond to any questions.
All right, thank you. Are there any questions from the committee? Seeing none, thank you very much.
Thank you.
Take our next testifier in support, please.
Good afternoon, Chairperson Hanson and members of the Health and Human Services Committee. My name is Maggie Ballard, MAGGIE-BALLARD, and I'm here today on behalf of Heartland Family Service. We are in strong support of LB 932 and would like to thank Senator Frederickson for bringing this bill forward. Just want to say a few things that as a community-based organization working with individuals to improve their mental health and or substance use, it is imperative that we have a timely licensing process. This process has become more time consuming, often taking months, leaving newly graduated and license eligible staff without means to practice or serve individuals while their documentation goes through the licensing process. This not only impacts the clients that need services, but also has a strong financial impact on agencies that have hired individuals that are unable to practice until the board approves their application. If we can allow individuals that are eligible for licensure to start working with clients immediately after applying for application, this will reduce the financial burden and increase the number of clients that our agency can serve and that are served across the state. So for these reasons, we ask you to vote LB 932 out of committee and into law.
All right, thank you. Are there any questions from the committee? There are none. Thank you very much. Anybody else wishing to testify in support of LB 932? All right, seeing none, is there anybody who wishes to testify in opposition to LB 932? Welcome.
I'm a little too short for this chair. Good afternoon. My name is Susan Meyerly, and I am here, spelled SUSANMEYERLE. And I'm here as chair of the Board of Mental Health Practice, the board that oversees and advises the applications for licensed independent mental health practitioners, licensed mental health practitioners, social workers, marriage and family therapists, and professional counselors, those that are most impacted by LB 932. According to Statute 38-126, it is the obligation of the Board of Mental Health Practice to govern and advise in a way that supports public protection. One of the concerns that we have with this particular bill is that it circumvents the process that's already been established for licensure in statute 38-161. The applications are currently processed when they are complete, and those applications that are completed are processed in less than 10 business days. Those applications include a description of the courses, the course transcript, a verification of the practicum with a signed affidavit from the practicum supervisor, and also a background check. Those policies were established, those criteria for application for licensure were established in support of the obligation of the board to protect the public. Applications that are incomplete are referred back to the licensee to provide additional coursework verification or address any other deficiencies within their application. It is these deficiencies that often create a delay in the issuance of the license. Do we really want applications with deficiencies serving Nebraskans? Consider this scenario of a license given under this current bill without the amendment that was addressed earlier. So you happen to be seeing a provisionally licensed person who received a license under this bill. After they received their license, the board recommended to the department that the license be rescinded. You are the client who no longer can see your provider because of deficiencies that were not addressed at the time of the application of the license. Talk about a discontinuance of care and a concern with public protection. What incentives would the applicant then have to address any deficiencies that were identified? Perhaps there was an oversight of a criminal background disclosure, which might preclude them from being licensed, and in the interim, they were seeing Nebraskans. Perhaps they were seeing you, or perhaps they were seeing your children. We are responsible to provide safe, effective care for Nebraskans and to protect the public. This bill, as originally drafted, does not protect the public. We would consider, as a board, the discussion of the amendment to propose to address the issuance of a license 90 days prior to graduation. I think this is a fair way to address those that are newly credentialed or seek to be newly credentialed so that they could obtain employment. That seems to be a responsible process. Unlike some of the experiences of the previous testifiers, both Ms. Schaaf, Ms. Devatney, and Ms. Ballard, who clearly have effective programs in place with working with practicum students, not all applications contain that high quality of practicum experience. And that is the obligation of the Board of Mental Health Practitioners to verify that applicants have in fact received appropriate supervision, as each of those that testified in support of the bill identify as so critical to their program. So therefore, the Board of Mental Health Practice is asking you to not move forward LB 932. I'll be happy to entertain any questions.
All right, thank you. Are there any questions from the committee? I don't see any. All right, thank you. Anybody else wishing to testify in opposition?
Good afternoon. It's
Welcome.
an honor to be here again. Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Dr. Timothy Tesmer, Timothy Tesmer, and I am the Chief Medical Officer for the Division of Public Health within the Department of Health and Human Services, DHHS. I'm here to testify in opposition to LB 932, which will allow applicants the ability to become a provisionally licensed mental health practitioner upon application and payment of the fee. The department has met with Senator Frederickson to discuss its concerns with the bill as written, and we are committed to finding a workable solution that addresses the following concerns. As written, LB 932 creates a serious public safety concern by allowing anyone, even those knowingly not qualified or those with criminal convictions, to apply and begin identifying themselves as a provisionally licensed mental health practitioner, PLMHP. This person would be able to provide mental health services to the public without first having their qualifications evaluated. The bill provides that if the Board of Mental Health Practice finds a PLMHP has failed to comply with the qualifications per statute, their license will be rescinded. Although the bill authorizes the board to rescind the provisional license of a mental health practitioner who fails to meet statutory requirements, the bill does not address the process for rescission. Most importantly, this is problematic because the bill does not address how the public would be protected during the legal process of rescission. The rescission of a provisional license would be a lengthy process because the licensee may have due process rights that would require specific procedures before losing the ability to practice. DHHS issues credentials to persons and businesses that provide health and health-related services for the purpose of protecting public health, safety, and welfare. Standards have been established in statute and regulations to ensure the safe practice of these persons and businesses. Applications and supporting documentation are reviewed prior to issuing a credential. For DHHS to issue a provisional credential without first having determined that an applicant meets those standards would pose a potential risk to the health and safety of Nebraska residents who need quality mental health care. Finally, this bill provides the transfer from a provisional license to a mental health practitioner license once a PLMHP completes certain requirements. DHHS is committed to working with Senator Frederickson on streamlining this process. We respectfully request that the committee not advance the bill to general file as written. Thank you for the opportunity to testify today. I would be happy to answer questions on this bill.
Thank you. Are there any questions from the committee? Seeing none. Thank you.
Thank you.
Anybody else wishing to testify in opposition to LB 932? Seeing none, is there anybody who wishes to testify in neutral capacity? Seeing none, we will welcome back up Senator Frederickson to close. And before he does, we did have somewhere in my pile of stuff 4 letters to the record, all in support of LB 932.
Thank you. Well, thank you to the committee for listening to the bill. As I mentioned in my opening, I have no intention to ask for the bill to be advanced as originally written. I want to thank the Department of Health and Human Services. Actually, the amendment that I filed was written by them. So I hope that with that amendment, we can all be in agreement with that. I do want to point out that, the original bill was exactly the way that the department had been issuing provisional licensure during the pandemic. So some of the testimony that was expressing some concerns about that, I can appreciate it, but that has been the department's practice during the pandemic. And with the amendment, we're going to certainly address the issues that were expressed and certainly want to ensure that the consumers are protected throughout. So happy to answer any additional questions as well.
Any questions? Seeing none.
All right.
Thank you.
Thank you.
All right. Then I'll close the hearing on LB 932. We will now open the hearing for LB 857. And welcome Senator Dungan to open.
Thank you, Chair Hansen. Good afternoon, Chair Hansen and the Health and Human Services Committee. I'm Senator George Dungan, George Dungan, and I'm introducing to you today my priority bill, LB 857. Before I get started, I would like to draw your attention to AM 2310. Does everybody have a copy of the AM in front of you? Because that's what I'll be talking about today. If not, I have a copy that can also be handed out.
It's in our shared drive.
Why don't we hand out a physical copy as well, just so we're all looking at the same thing? AM 2310, which is being handed out to you, does replace the introduced bill, and it's what I would be asking we move forward on. AM 2310 is the result of months of work with the Department of Health and Human Services, MCOs, and other stakeholders involved in this matter. In that amendment, you'll find tightened up definitions that better reflect what the intent of the bill was, and we've also removed a few provisions that were unnecessary and costly. The AM also clarifies that this is for prenatal care only and not postpartum care, but I'll speak more about that in a little bit. The fiscal note also reflects 18 months of care, but the AM only is for the prenatal time, which is estimated at about 6 months. We'll get more into this later. LB 857 would create the Prenatal Plus program within the Department of Health and Human Services. The purpose of the Nebraska Prenatal Plus program is to reduce the incidence of low birth weight, preterm birth, and adverse birth outcomes, while also addressing other lifestyle, behavioral, and non-medical aspects of an at-risk mother's life that may affect the health and well-being of the mother of the child. In Nebraska, our MCOs already currently offer a fairly robust package of prenatal services, and for that, we're all very thankful. LB 857, however, would make certain that additional and necessary prenatal services would be eligible for Medicaid reimbursements. Particularly, this would add up to 6 or fewer sessions or meetings with a nutritionist in order to help with diet during the prenatal period. And then also, and keyly, this program would provide for targeted case management, or TCM, to be reimbursed under Medicaid. A case manager would help coordinate between the expecting mother and other types of services best suited to their needs. Before I continue, I want to take a second to give you a little bit of background about kind of how we got here. LB 857 really does represent the culmination of an entire interim's worth of work trying to find a bill that I thought would be able to help mothers here in Nebraska and ultimately help babies. At the end of last session, I almost immediately started focusing on what we could do this session that would accomplish 2 different goals. One, be a bill that ultimately helps people and provides actual benefit for Nebraskans. And 2, was an issue that was representative of something that we could all agree on, something that brought us together, something that was bipartisan, nonpartisan in nature, that ultimately I think we could all agree on. So as I was doing that research and thinking about what fit that bill, ultimately what I landed on was one thing I think we can all agree about is we need healthy moms and healthy babies. And that became sort of the guiding light of what I was trying to figure out we could ultimately try to get done here in Nebraska. What's going to be helping us keep babies healthy and mothers healthy? So I started searching in other states to see what they've done in order to ensure access to prenatal services that ultimately have documented benefits. I came across a program in Colorado, which is conveniently called the Prenatal Plus program. And in that program, there was a number of things that caught my eye. First of all, it's a Medicaid-based program that was implemented in the late 90s. So we have decades of data, hard data from the state of Colorado that allows us to look what the benefits are for the services they implemented. And in addition to that, it gave us a couple of different metrics we could look at to see if this was really working. So Colorado ultimately issued some reports in 2001 and in 2007 to make sure that this Prenatal Plus program was beneficial. And I can provide the committee with more copies of that, but we can talk offline about that as well. And the 2 things in those reports that I thought were just incredibly impactful were, one, the services that were being implemented to help moms prenatally had a substantial and significant reduction on low birth weight babies. And the fact that they actually were able to see that benefit was huge. In addition to that, their own documented studies in 2001 and 2007 demonstrated a systemic and ongoing cost savings. I believe the 2001 study with regards to their Prenatal Plus program recognized for every $1 that was spent in the Prenatal Plus program, there was a $2.48 savings net for Medicaid. So they ultimately, in analyzing how much money Medicaid was spending on moms, saw a massive reduction. So both of those things caught my eye. So I started thinking about what we could do here. Now, the adverse birth outcomes, like low birth weight being the main one, have a multitude of negative effects. And I know I'm talking to the HHS committee. I probably don't have to explain that to you. But low birth weight leads to vision problems, respiratory complications, cognitive impairment, gastrointestinal issues, higher death rates, lower performance at school. All sorts of issues come from these adverse birth outcomes, specifically low birth weight babies. So we immediately said we should be doing something like this here in Nebraska. Obviously, our Medicaid system is very different than Colorado. The Colorado program, when I dove into that, was very top down. It told people what to do, said that you have to go to X amount of meetings, you have to do this amount of services, you have to hire these people to be eligible for reimbursements on this, which I thought caused a big problem. And that's not how I wanted to do things here in Nebraska. So we began to partner with other stakeholders, talking to our friends, the MCOs, First Five, other individuals who frankly know a lot more about the systems than I do, to see what we could do in Nebraska that was very similar. And we worked with DHHS over the interim, meeting with them multiple times, talking with the MCOs, and ultimately came up with the legislation that is before you in the amendment, which again is essentially the same as LB 857, but with more definitional clarification and then a few extra little tweaks. The fiscal note is something I wanted to talk about as well briefly before we get into the testimony. The fiscal note before you reflects the bill as written under LB 857. It does not reflect the amendment. The language of the bill, I think, caused some confusion in seeming to imply that these services would be available to moms both prenatal and postpartum. Therefore, the entire term that it was being analyzed for was the 6 months being estimated for prenatal, along with 12 months postpartum. That was never our intention, and certainly the name Prenatal Plus implies this is intended to be a prenatal bill. And so we did ensure in the amendment that it clarifies this is just the prenatal period of time. In addition to that, DHHS and their analysis did differ slightly from what the fiscal office had put in there. I won't dive into all the details yet. We might talk about it more in closing, but ultimately the fiscal office did estimate slightly lower costs for things such as targeted case management. The reason for that is targeted case management is a term of art. And I think some of the testifiers who come up after me will do a better job of describing this. But targeted case management, as we intend it, is, for lack of a better way to put it, an air traffic controller who has consistent contact with the mom. They know your history, they know your background, they know where you're coming from, and they can help direct you to other services. It is not meant to imply like an in-home case manager or something like that. So I think in the initial exploration of what the cost would be for that case management, it was viewed more as like developmental disabilities in-home services, and that was never the intention. So the AM before you also has the definition of targeted case management referring to the CFR, clarifying our intention for more of these in-house provider services to sort of direct you to other people, not somebody who's going to come into your home. That, I think, is reflected in some of the analysis that is different. Based on what is calculated in the fiscal note and taking out that postpartum, I did the most math I've done in the last 20 years of my life over the last couple days. My estimate, so don't hold me to this, the fiscal office could do a better job, is that adopting the amendment and appropriately accounting for the cost of the targeted case management, the impact yearly to the general fund of Nebraska would be between 1.3 million and 1.7 million. That is a significant reduction than what I think is reflected in that fiscal note, but that's because the amendment has not yet been adopted. So I want to clarify when we're talking about what this is going to cost Nebraskans for essential services, it's significantly lower than before you. So I will wrap up. I can pontificate about this for a very long time, but we do have some testifiers who are coming in behind me who I think will talk about a number of different areas that might clarify this for you. You're going to hear from Chad Abrish from UNMC to talk to you about how Prenatal Plus has worked in other states. Dr. Ann Anderson-Berry from NPQIC to kind of clarify to you what adverse birth outcomes are and what the stats are in Nebraska. You're also going to hear from ACOG, and they're going to discuss with you what the challenges for those adverse birth outcomes are and what additional supports could fix. You're also going to hear from the Catholic Conference to talk more about the moral issues of ensuring that we're supporting moms during their pregnancy. You're also going to hear from Nebraska Right to Life to talk about similar issues. You're going to hear from Nebraska Appleseed, and then finally you'll hear from Sarah Howard from First Five Nebraska to go into more technical questions and probably answer those much better than I could. That being said, happy to answer questions for you now, and thank you for your time.
All right, thank you. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hansen, and Thank you, Senator Duncan, for being here today. Can you just repeat the number, the estimate you said one more time after the amendment would be adopted for the fiscal note?
Yes.
1.3 million to.
I think it'd be between 1.3 million to 1.8 million, and that's the Nebraska general fund impact. So obviously that's not accounting for the federal money that would also be put in.
Got it.
The reason for that is I kind of extrapolated out from the fiscal note how many visits they were anticipating for a prenatal term for both targeted case management and nutrition counseling, factored in the costs that the fiscal department was estimating for both of those things, multiplying it by the number of moms that are estimated to have adverse birth outcomes based on the NHA's data as to how many babies born have neonatal codes assigned to them, and ultimately then taking out the postpartum care and just estimating it for those 6 months during preterm or prenatal rather. That's kind of where I got to that 1.3 to 1.8, depending on how much targeted case management is. I'd also like to highlight briefly that that is the hypothetical maximum amount. That's assuming that every mom who's eligible for these services, and I hope they do, takes advantage of them. But we know obviously not everybody takes advantage of that. And those who do decide to take advantage of those programs don't always go through the entire course, right? So if you go to 1 month of nutrition counseling, you may not go to the next 5. And so I think the number that we're looking at here is a ceiling, and that's important to keep in mind as well.
Great, thank you.
Any other questions? Seeing none? I'm assuming you're staying closed?
I will.
Okay, all right, we'll see it closed. And just a note for everybody, in the essence of time, since we have a number of testifiers, we will go down to 3 minutes for testimony for each person here. So. Close to 3 minutes. Anyway.
Good afternoon, committee. I'm Rebecca Wells, REBECCAWELLS, and I'm jumping in because I want to say what I'm going to say, and then we'll let these other people go ahead. I was thrilled to see this and jumped onto it. I'm here representing myself. I have a background as a certified nurse midwife. I spoke before you last fall, and I was very much against the abortion ban. I guess my big concern, I'm very concerned about babies, but I'm concerned about mothers. And what I was so thrilled to see with this was that it went up to the first year. And yes, Nebraska has a big problem with low birth weight and preterm births. They have a D- from the March of Dimes in 2023. Their rate has jumped up. It's 11.3% preterm births, the highest in 10 years. But guess what? And this would be a wonderful program. And I was so thrilled to see the mental health. And I thought, oh, good, because guess what? Maternal mortality is a huge problem. It's worse than infant mortality. Infant mortality in this country and Nebraska is kind of a little up and down. Maternal mortality has jumped up in the last few years particularly. It has really jumped up in states that have put abortion restrictions. And I don't know if you all realize, and if you've been mothers, you know, having a baby is so stressful. Women that have any mental health issues, and mental health issues are huge. They've really gone up with the pandemic. Once they have a baby, a lot of it is lack of sleep. A lot of women with mental health issues have more unplanned pregnancies. In the past, they might have terminated a pregnancy with a serious mental health issue or with a substance abuse issue, and now they can't. And the biggest risk of suicide, which is estimated to be about 20% of maternal death, and we're talking now first year afterwards, which now is what they're looking at instead of the first 42 days, 20% due to suicide. The biggest suicide risk in mothers is between 9 and 12 months after birth. So we really have responsibility. And I am disappointed to hear that we're cutting it. And also you think of the care of the infant. Women that are stressed, how are they going to be coping and caring for a child at a critical time for their later development in that first year. So I think it's a wonderful bill. I liked it the way it was written, and I'm disappointed to hear it's ending at delivery. Thank you. Do you have any questions for me?
All right, thank you. Are there any questions from the committee? Yes, Senator Kavanaugh.
Thank you. More of a clarifying point.
Yes.
Thank you so much. We actually did pass Medicaid postpartum coverage
I
last
saw
year,
that.
and
I
it-
saw that.
And it has been adopted up to a year. So we do have that important coverage that you.
I was so happy to see that. Now, and
This
I'm
is a-
hoping,
this
does that
is
still,
covering-
does that cover mental health visits
It
too and everything?
absolutely covers
Good,
mental health.
excellent.
And
Well, I feel better.
Senator Dungan's bill is more specific to the needs prenatal that are
Okay.
going unaddressed of nutrition. But thank you for your vigilance
Okay.
and your testimony.
Thank you. I had seen that bill and I didn't have a chance to get here and talk to you about it. I'm so glad I hadn't checked to see what happened. I was going to do that. Thank you so much.
All right, thank you for your testimony. We'll take the next testifier in support of LB 857. Welcome.
Good afternoon, Chairman Hansen and members of the committee. My name is Chad Abrish, that's ChadAbresch. I'm chairperson for the Department of Health Promotion at UNMC and senior advisor for CityMatch, which is a national maternal and child health organization. Today, I'm testifying as an individual and my position does not represent that of UNMC. I'm here today to voice my support for LB 857, which would bring Prenatal Plus to Nebraska. I've been involved with Prenatal Plus nationally for over a decade in both Colorado and Florida. Now, to state the obvious, Colorado and Florida are two very different states. Their politics, populations, and healthcare systems differ greatly. And yet Prenatal Plus is a perfect fit in both. Why is that? Because Prenatal Plus doesn't overcomplicate things. It simply allows doctors to identify high-risk pregnancies and then provides extra care for those women. In that way, Prenatal Plus is just common sense. In preparing for today, I called Claudia Marana, director of the program in Palm Beach County, Florida, to see how things were going. Claudia told me, Chad, after 10 years, Prenatal Plus is still going strong. It continues to work well because it targets services exactly where they are needed. Palm Beach County originally adopted Prenatal Plus because nearly 4 times as many Black babies were dying compared to white babies. They wanted to do something about that specifically, and they did. I attached an email to my testimony from Jeff Goodman, who's an evaluation officer in Palm Beach County. Jeff's email to our team at CityMatch shares data after 5 years of their implementation of Prenatal Plus. And the data demonstrate that the disparity in Black-white infant mortality had been more than cut in half. You can see in his data, and I highlighted it there, that Palm Beach County had achieved the lowest Black infant mortality rate in the state and had reached the Healthy People 2020 goal a full 3 years ahead of schedule. In fact, for all counties in our nation, Palm Beach County was one of only 5 that ever achieved the Healthy People 2020 goal for infant mortality for Black populations, which is truly impressive. I mentioned that Prenatal Plus worked well in Florida and Colorado, so I've attached some Colorado data too. If you'll allow me to get a bit nerdy with the data, I'll ask you to look at the columns that I've circled. I want to make 2 points here. First, in Table 2, you can see high percentages of pregnancy risks were overcome through Prenatal Plus. 62% of the women with inadequate weight gain, for example, were able to resolve that challenge. Even in the last row, where you see the highest risk pregnancies, women facing an onslaught of very significant challenges, here 20% of women receiving Prenatal Plus were able to overcome all of those challenges. This is remarkable. Now, the second point in Table 3, you can see just how important resolving those challenges is for reducing preterm birth. I see that the light is red, so out of respect, I can stop there.
Yeah, I think you have just a little bit left, so you can just wrap up your final thoughts.
Okay, thank you. It's worth doing a little math here because while adding services does come with a cost, it also produces savings. The March of Dimes calculates the first-year medical costs for an infant born prematurely at $49,140. That's compared to just $13,024 for a term delivery. So let's imagine Prenatal Plus reaches 1,000 women in Nebraska in its first year, with 40% of those women resolving their high-risk challenges. That's a bit conservative based on what we know Prenatal Plus can do, but let's go with it. This would represent 400 pregnancies with about a 7% likelihood of preterm birth, instead of a likelihood of about 13%. This translates into 28 preterm births with an estimated total of $1,375,920, rather than 52 preterm births with a cost of $2,555,280. This estimate represents a savings of over $1 million for the first year of Prenatal Plus. But let's stop right there, because money is not the reason we're doing this. We're doing it to save lives. CDC's most recent data on prematurity shows an infant mortality rate of 34.69 for every 1,000 infants born less than 36 weeks gestation. But that rate is just 2.18 deaths for every 1,000 births born at more than 30 weeks, 7 weeks gestation. So when you calculate that out, what you see is that if we could expect among those hypothetical 1,000 Nebraska women enrolled in the program, we would see that 2 more of them would be buying cake and singing happy birthday in a year's time, rather than saying goodbye much too soon. 2 lives saved every year, Senators. That's a profound possibility. The importance of this bill should not be understated. Thank you.
That's a good job wrapping up your final thoughts.
Thank you.
All right, any questions from the committee? All right, seeing none, thank you for testifying. Take our next testifier in support.
Chair Hansen, members of the Health and Human Services Committee. I am Dr. Ann Anderson-Berry, ANNANDERSONBERRY. I'm a faculty member of UNMC and the medical director of the Nebraska Perinatal Quality Improvement Collaborative, NPIC. However, I'm not speaking as a representative of the university today. I'm here speaking as an individual and on behalf of the Nebraska Medical Association, as well as the Nebraska Perinatal Quality Improvement Collaborative. I'm here testifying with regards to LB 857. As a medical director of NPIC and a neonatologist, I work with hundreds of families each year with high-risk medical situations for both mother and baby. Through NPIC, we support healthcare professionals across the state who can provide care that leads to best outcomes for Nebraska mothers and infants, working to ensure that every family has the healthiest start possible. This bill, proposing a support for Prenatal Plus program, is designed to improve the health of mothers, to decrease adverse neonatal outcomes, and improve maternal outcomes. In Nebraska, the rates of adverse neonatal outcomes, such as low birth weight, less than 2,500 grams, preterm birth, and adverse birth outcomes, such as brain injury from hypoxia during delivery, are increasing in frequency. Increased adverse neonatal outcomes drive admissions to the neonatal intensive care unit, or NICU. The care I provide in the NICU relies on advanced technology, equipment, medications, and highly trained large healthcare teams. This is expensive and requires extensive commitment from families who are hospitalized for months. As reported by the March of Dimes, Nebraska's preterm delivery rate rose from 8.7% in 2013 to 11.3% in 2022. And we have an infant mortality rate of 5.5 infant deaths per 1,000 live births, with minority infants dying at 3 to 4 times the rate of white infants. Minority infants are dying at 3 to 4 times the rate of white infants. This is an unacceptable public health outcome. Many maternal factors that drive preterm birth are modifiable, including unhealthy weight, diabetes, hypertension, and smoking. When looking specifically at obesity, defined as BMI of 30 or greater, the percentage of obese women delivering preterm infants in the 34th through 36th week of pregnancy, the weeks accounting for the majority of preterm infants, has increased from 27 to 37% over the last 6 years. Diagnosis of gestational diabetes has increased in these mothers by 5% over the same time, from 8 to 13%. These diagnoses are not only associated with preterm delivery, but also with the need for medically induced deliveries and C-sections in Nebraska, increasing cost and risk to the mother and infant as compared to term spontaneous labor. You can see my figures A through C. This is Nebraska data. Infants are the only ones to bear the burden of adverse perinatal outcomes. Mothers with hypertension, obesity, and diabetes are at increased risk for delivery by C-section, postoperative infection, postpartum hemorrhage, and long-term cardiovascular disease. Intervention early in pregnancy with a Prenatal Plus program to address lifestyle, behavioral, and non-medical aspects of an at-risk mother's life have been shown effective in Colorado and California. I see my light is gone, so I will skip to the bottom. I urge you to pass LB 857 to provide this common sense program to high-risk Nebraska mothers. I'd like to thank Senator Dungan for introducing this important legislative bill. Thank you.
Thank you.
Happy to answer any questions.
Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thank you, Dr. Anderson-Berry, for being here. The stats around gestational diabetes. So as the law is currently, there's a population of mothers or expecting mothers that aren't covered. Are they going undiagnosed for gestational diabetes? Or
are you talking about the CHIP 599?
Yeah, sorry. Yes.
Oh, that's okay. Yes. They are able to get prenatal care under CHIP 599. And if they get early prenatal care, they should be able to be diagnosed. But ideally, we would start this Prenatal Plus program, and then those mothers could get nutritional counseling and perhaps avoid their diagnosis of gestational diabetes, avoid an expensive NICU stay, and avoid harm to those infants.
So they currently aren't getting, they can get the diagnosis, but they aren't getting the preventative in advance of the diagnosis of the nutritional.
No, we don't have coverage like this program right now.
And I forgot, sorry, what my next question was going to be. At what point do you get to have that wonderful glucose screening test?
That's mid-trimester, so around 22 weeks.
Okay. For those that don't know what this is, it is a torture device that requires pregnant women to fast. So,
and then drink a sickly orange drink.
Yes. So if your partner ever has to go through this, please be kind and patient with their hangriness. Okay, thank you very much.
Thank you.
I have a question.
Yes.
In your opinion, because obviously I'm looking at some of the data that you presented here, and a 5.5 increase in gestational diabetes within 5 to 6 years is pretty significant.
It's atrocious.
So I'm tying this into part of the bill that has to do with 6 or fewer sessions of nutritional counseling. Can you elaborate a little bit more on what the nutritional counseling would entail, in your opinion? You know?
Yeah, I do nutrition research in the perinatal period. I will give you the caveat that I'm not a registered dietitian. I'm a physician. However, this would counsel women on the quality of their diet, having a diet rich in micronutrients, having a diet that's rich in whole grains, and decreasing elements of the standard American diet that include highly processed foods, which have high levels of carbohydrates and high fructose corn syrup, and those in combination with the pregnant state put women at significant increased risk for development of gestational diabetes. So that would be what I would anticipate that counseling would entail. And modifications early in pregnancy can impact the results of nutrition in pregnancy. That's what I spend, when I'm not here, that's what I spend my life doing.
Okay. I think it's kind of what I figured. I just wanted to
it's
kind of
really
verify
important.
that. So.
And this is cheap and modifiable. And you don't want me to take care of a baby that's under insurance from the state. I come with a pretty hefty price tag.
So pretty much tell them to stay away from the food pyramid.
Well, yeah, our standard American diet, otherwise known as SAD, is.
All right. Any other questions? Seeing none. Thank you.
Thank you.
Let's take our next testifier in support, please.
All right. Chairman Hansen, members of the Health and Human Service Committee, thank you for allowing me to speak with you today. My name is Dr. Mary Kinyon, Marykynyoun. I am an OBGYN physician here in Omaha, Nebraska, and I am here today to testify in favor of LB 857 on behalf of the Nebraska section of the American College of Obstetricians and Gynecologists. We feel strongly that the Prenatal Plus program has great potential to positively impact the health of women and babies in our state. When a woman begins prenatal care and has her first visits with her healthcare provider, a detailed medical, surgical, family, and obstetric history is obtained. In addition to reviewing data like labs, vital signs, and physical exam findings, we also discuss our patient's mental health, screen for substance abuse, domestic violence, and food insecurity. Compiling this information allows us to identify those who are at risk for preterm birth and low birth weight. While we may increase visits, frequency of visits, or ultrasounds as things stand now, there are very few systems-based interventions that we can offer our patients. While some clinics have social workers who can help give lists of resources, many patients would benefit from additional assistance and more extensive and personalized care coordination. When I think of who the Prenatal Plus program could benefit, countless patients come to mind. I think of a mother at 26 weeks who had inadequate weight gain, who revealed she didn't feel she had sufficient funds to feed herself and her 2 growing children at home. Then there is the woman who was living out of her car during a portion of her pregnancy, who later went on to deliver prematurely due to pregnancy complications with a low birth weight baby. I've also cared for a number of pregnant patients in substance abuse recovery who would have benefited from additional case management, for mental health support, tobacco cessation, and aid with finding safe and sober housing. Many women we care for who are at risk of preterm birth not only have these socioeconomic barriers to having a healthy pregnancy, but have other medical comorbidities such as diabetes, high blood pressure, or obesity. The ability to offer increased nutrition counseling and educational resources surrounding this could help us prevent significant maternal morbidity and in turn neonatal morbidity as well. We do the gestational diabetes test between 24 and 28 weeks. The ability to offer nutrition counseling at the start of pregnancy could truly help decrease rates of gestational diabetes, elevated blood pressure, and excessive weight gain in pregnancy. We know that socioeconomic instability and maternal stress can result in adverse pregnancy outcomes, including preterm birth and infants with low birth weight. In the United States and here in Nebraska, this is affecting Black and other minority women and babies at higher rates than their white counterparts. In a time when we are in a maternal and infant health crisis in this country, we should be adopting programs like the Prenatal Plus program that have made substantial differences in other states. I'll wrap up here. From an obstetric perspective, there is not a magical pill or procedure that we can do to reliably prevent preterm birth in babies born with low birth weight. Socioeconomic stressors, food insecurities, mental illness, and addiction contribute to very real physiologic stress on pregnant mothers and fetuses. Mitigating even a portion of this could allow women to have healthier pregnancies. Nebraska ACOG would like to thank Senator Dungan for introducing this bill and urges you to support the Prenatal Plus program. Thank you.
Thank you. Any questions from the committee? Seeing none. Thank you.
Thanks.
Take our next testifier in support, please. Welcome.
All right. Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Marion Miner, M-A-R-I-O-N-M-I-N-E-R. And I'm here on behalf of the Nebraska Catholic Conference, which advocates for the public policy interests of the Catholic Church and advances the gospel of life through engaging, educating, and empowering public officials, Catholic laity, and the general public. Catholic social teaching, in accord with sacred scripture, affirms the preferential option for the poor. That, quote, the poor, the marginalized, and in all cases, those whose living conditions interfere with their proper growth, should be the focus of particular concern. The preferential option for the poor has a special form of primacy in the exercise of Christian charity and applies importantly not only to our individual actions, but to our broader social and political responsibilities. Mothers of preborn and newborn babies who are without adequate family and social support ought to be of special concern and must be a special focus for society attempting to realize a culture of life. This is the basis of the conference's support for LB 857, which would create the Prenatal Plus program. This program would provide additional help for those mothers who are eligible to receive care under Medicaid and need special support for healthy pregnancy and childbirth. Factors such as inadequate or poor nutrition and untreated physical or mental health disorders are addressable and directly related to the long-term health of a mother and her preborn or newborn child. A program that incentivizes the identification and treatment of those issues for low-income mothers, as LB 857 would do, is, in our judgment, worthy of support. And our understanding is that there are ongoing conversations taking place between Senator Dungan's office and DHHS, as he alluded to, of course, to address cost, the fiscal note, and concerns about duplication of services. And we encourage the committee and the department to work those out and advance an amendment that would fill those gaps that do exist for mothers and their babies who would qualify for this program. Thank you very much.
All right, thank you. Any questions from the committee? Seeing none, thank you.
Thank you.
Take our next testifier in support.
Good afternoon, Chairman Hansen, members of the committee. My name is Sandy Danek, SandyDanek, and I'm the Executive Director of Nebraska Right to Life. I'm submitting this testimony in support of LB 857 as it has been presented to the committee. Our mission at Nebraska Right to Life is to restore legal protection to innocent human life from fertilization through natural death. We work on policies to oppose abortion, infanticide, euthanasia, and unethical biomedical research. We believe the intent of LB 857 falls within our scope to promote a culture of life. Implementation of the Nebraska Prenatal Plus program will promote this culture of life by assisting at-risk mothers with nutrition counseling, psychosocial counseling with support, general client education, health promotion, breastfeeding support, and targeted case management. Providing these services to at-risk mothers will offer the tools needed to help them through personal challenges and better secure the delivery of a healthy infant, as well as foster a positive, loving environment for both mother and child. The annual reports will provide the state with valuable data to show how the Nebraska Prenatal Plus program is helping mothers and their babies, which we believe will be an important element to further assist at-risk mothers. We encourage you to advance LB 857. Thank you for your time.
Thank you. Are there any questions from the committee? Seeing none, thank you very much. Take our next testifier in support, please.
Chair Hansen and members of the Health and Human Services Committee, my name is Sarah Marish. It's SarahMaresh. I'm the Healthcare Access Program Director at Nebraska Appleseed, testifying in support of LB 857 on behalf of Appleseed. One of our core priorities is working to ensure that all Nebraskans have equitable access to quality, affordable health care. Because this bill seeks to improve prenatal health supports for at-risk pregnant people with Medicaid coverage, which can help improve outcomes for babies and families, we support this bill. Receiving regular and comprehensive prenatal care, as you heard, is critical for the health of new families. It's well established that insufficient prenatal care contributes to adverse health outcomes for babies, like preterm birth or low birth weight. And quality prenatal care and support is connected to improved physical and psychological outcomes for newborns and their families. Despite its importance, in 2022, 20% of Nebraska's babies were born to moms who did not receive adequate prenatal care. Improving prenatal services and access to care for those with Medicaid is particularly important. First, Medicaid covers thousands of births each year in Nebraska, which means Medicaid is a critical tool in supporting the health of our newborns and communities. Medicaid covers approximately 35% of all births in Nebraska, often covering those most at risk for having adverse birth outcomes. Low-income individuals covered by Medicaid tend to face more chronic conditions and risk factors that can negatively impact maternal health and birth outcomes. That, coupled with the fact that people with Medicaid are less likely to receive adequate prenatal care when compared to their privately insured counterparts, clearly demonstrates the need to improve prenatal care supports in Medicaid. Even more, improving these supports may also help reduce severe racial disparities that exist in maternal and infant health. This bill's specific services identified for the at-risk population are also uniquely situated to address key prenatal care deficiencies. Specifically, the case management service you've heard about today is a flexible support that can be tailored to individual specific needs, which leads to more targeted care. The case management can help address a multitude of factors and social determinants of health that contribute to these adverse birth outcomes, which paves the way for more comprehensive and holistic care. Nutrition counseling is also of prime importance in the prenatal period. Finally, we also support the report that's called for under this bill, as it increases public transparency and will be critical in evaluating the impact of this program. For these reasons, we respectfully request that you advance LB 857. Thank you.
Thank you. Are there any questions from the committee? I don't see any. Thank you very much. Hey, wait, have you had the glucose testing done yet?
I have, yes.
Is it as bad as they say?
You know, it's like flat orange soda, I would say. So if you like that, then go ahead and drink it. Yeah.
I will pass, but.
Thank you.
All right. Take our next testifier in support, please.
Good evening, Scout Richters, SCOUTRICHTERS, here on behalf of the ACLU of Nebraska in support of LB 857. The ACLU of Nebraska works to ensure that Nebraskans can make important decisions about having and raising children with autonomy and dignity and have the resources they need to ensure that their families thrive. This work includes ensuring Nebraskans have access to birth control and abortion care, prenatal and maternal health care, and that the rights of pregnant and parenting students and workers are protected. Every pregnant person deserves to receive quality prenatal medical care, yet this is far from the reality, as you've heard from other testifiers. Creating the Nebraska Prenatal Plus program will help to address disparities in care, further access to necessary care for pregnant Nebraskans, and improve the lives of Nebraska families and children. We offer our full support for this legislation and would urge its advancement.
Thank you. Are there any questions from the committee? Saying none, thank you. Take your next testifier in support, please.
I believe I'm your last one for this lovely bill. Okay, Chairman. Okay. Chairman Hansen and members of the Health and Human Services Committee, thank you for allowing me to testify today. My name is Sarah Howard, spelled SARAHOWARD, and I'm a policy advisor at First 5 Nebraska. First 5 Nebraska is a statewide public policy organization focused on promoting quality early care and learning opportunities for Nebraska's youngest children. My position at First 5 Nebraska is focused on the area of maternal and infant health policy because we know that healthy moms and babies are critical to ensuring the long-term success of children in our state. I'm here to testify in support of LB 857. First, I want to commend Senator Dungan for his support of children and families in the state of Nebraska. I'm just going to kind of tell you how this came about. So Senator Dungan was very curious over the summer, like, what are some things that we can do, like he said, that are bipartisan, where like we can agree on. And one of the things we can agree on is that moms deserve prenatal care that's adequate and meets their needs. And so he called me and said, well, have you ever heard of this program? And I said, absolutely not. I've never heard of this program, but it sounds very nice. And I started just doing some digging into what Prenatal Plus meant and trying to compare our Medicaid program to Colorado's program. And that isn't an apples to apples comparison. You guys have heard the joke when the MLTC director comes and talks to you and he's like, if you've seen one state plan, you've seen one state plan in Medicaid. And so comparing the Colorado program to our program was not exactly the same. And so what Senator Dungan was able to put together in the bill before you is something that's very Nebraska tailored. It identifies mothers who are at risk of an adverse birth outcome, specific preterm and low birth weight, which we know is a problem. And I'm going to remind you guys of last week. I was here on Friday, right, for the hospital assessment, and they had given me their claims data for the first 3 quarters of 2023. And from that claims data, 48% of babies born to mothers who were covered by Medicaid had a neonatology code, which meant they were low birth weight, preterm, or they had to have a transfer, or the codes also include a fetal demise. And so 48% of babies born to Medicaid mothers are having these major issues. And so having a program that directs interventions for their needs, like targeted case management, so those additional supports, and like nutrition counseling specifically, would, while it does have a cost, right? We've got that general fund impact. I believe we would see a similar savings to what Colorado saw, which was pretty remarkable in their Medicaid budget. So I'm going to just talk about the cost very quickly in my last minute. I'm going to grab the fiscal note for you, this lovely fiscal note. And really with the amendment, what you are looking at is this table down here, that's 6 months, right? That's circled. And that's 3.8 million. That's 3.8 million before you get your federal match. The federal match on 3.8 is the 2.2 million. So that's what gets you down to 1.6 of general funds. This 1.6 of general funds would be an appropriate use to look at a cash fund or a pay for, like the Medicaid Managed Care Excess Profit Fund. This would be an appropriate use for that. That being said, I think the savings to the state would actually be quite a bit more than we would anticipate because of that high rate of prematurity and low birth weight that we see. It's the highest I've seen in a state. And generally overall for babies in the state of Nebraska, it's like 18%, but for Medicaid mothers, it's almost half. That is bananas. And with that, I'm happy to answer any questions that you might have.
Thank you. Are there any questions from the committee? Senator Kavanaugh.
Can you continue explaining this to us?
Sure, which part?
Oh, just
All of it?
the fiscal note.
Yeah.
Can you kind of take us through it a little bit slower?
Yeah, I was on
I know.
the clock. I was on the clock.
No judgment. No judgment.
Okay, so the fiscal note has to consider first how many moms we might be, who might be eligible for this service. And then they have to figure out how much the service costs. There are only two services here that are new, the nutrition counseling and the targeted case management. The nutrition counseling is honestly kind of cheap. Dietitians are not very expensive in terms of their provider billable codes. And so when you limit them down to 6 visits, that's negligible when you consider cost. The targeted case management, the only comparison we have in the state of Nebraska for TCM is NDD. And that, as you know, is a super intensive population that is a more expensive service compared to a highly motivated population for a limited period of time, right? We're looking at 6 months because we know entry to care for mothers in Medicaid is usually in the second trimester, which is not good. Also not good. We'll find another bill to fix that. And so you figured out how many people you have, you figure out the cost of the service, and that's what's getting you to those cost estimates that are at the bottom of the fiscal note. So I think DHHS thought every single mother on Medicaid would be eligible for these, and that's not accurate. It's probably less than half. And then when you think about Chad Abrish's testimony, there were several states where they implemented Prenatal Plus, and the moms didn't take up the case management, right? So maybe it was like 25% of the moms. So when you think about the actual cost, it may be significantly less than this if people are not taking up the service. But the importance is the availability of the service. So even if 25% of moms took up the service and we were able to evade a bad birth outcome, that saves us an enormous amount of money in NICU costs and costs to the state once that baby is here. Did I do it all right?
Well, I'll give you A- for today.
All right, well, I tried my best.
I have a follow-up question. Okay, so actually two. The first one is, I'm going to ask them together and then leave it to you.
Yeah.
The first one is, so the 25%, so this is basically we're expanding a service array. Not every mother has to go through this. It's optional. So we will see it's not 100% participation. And then the second question is the TCM. How does that work?
Sure. Okay.
That's a very open-ended question.
Let's do the first one, the narrowing.
Yes.
That we won't have very many. If we estimate that there were 4,000 moms with an adverse birth outcome, maybe they were identified, maybe they weren't. If you narrow that down to 25% of them, that'd be about 1,000 moms who may take up the service and be identified for this adverse birth outcome, which really lowers that fiscal note. However, we write fiscal notes to the max number so that you guys can budget effectively, right? So targeted case management is, like Senator Dungan said, it's a term of art in Medicaid for billing purposes. So it starts with an assessment, it's 3 visits, and then it's sort of like a completion moment. So it's 5 interactions is what the CFR requires. And then you can bill out for that service. What we're specifying is that you want that social worker or that care coordinator to be in that clinical setting as opposed to a third party or somebody outside of that doctor's office, because you want them coordinating care, not just with the OB, but with any other tertiary care that mother might need. So TCM is essentially case management, but it's in a very limited scope and structure, which is why the cost of it is not very expensive. It's from a less expensive provider.
Okay, thank you.
Oh, it's a good question. Thank you for the good questions. I really appreciate them.
Are there any other good questions?
The only bad ones now.
Which is, I don't know if it's a good question.
Is it about my tweets?
This is your last hearing?
I'm kidding. I'm
Too soon.
Too soon. Too soon. Too soon.
They're all about cats anyway.
I know they are all about cats. This is my last hearing. This is my last visit with you this year.
I was
I've had a
going
lovely
to,
year.
that was my question, because I do see it's after 5 o'clock and the next bill is about the Opioid Recovery Fund. So you could come up in a personal capacity, just, putting that out there for you.
No, but I'm gonna watch it and send you guys lots of love as you consider it.
Thank you.
Okay, seeing no other questions, thank you.
Thank you for having me.
Anybody else wishing to testify in support of LB 857?
Hello, Chairman Hanson, members of the Health and Human Services Committee. My name is Marcia Muting, MarciaMueting. I'm a pharmacist and I'm the CEO of the Nebraska Pharmacists Association. I am just going to take a minute in the chair to say that the Nebraska Pharmacists Association supports LB 857. Many thanks to Senator Dungan for introducing the bill. I'm not going to read this to you, and because I know you can read. And I just want to let you know that the pharmacists in Nebraska think this is a really important and essential step in the right direction for healthy moms and healthy babies. So I'll take any questions if you have them.
Thank you. Are there any questions? Seeing none, thank you. Is there anybody else wishing to testify in support of LB 857? All right, seeing none, is there anybody who wishes to testify in opposition to LB 857? Anybody wishing to testify in a neutral capacity? All right, seeing none, well, welcome back up, Senator, to close. And for the record, I think you did have the most kumbaya bill so far of the year.
Hey.
Considering the diversity of, testifiers. And you'd also had 25 letters for the record in support and one in neutral, so.
Thank you. And thank you, members of the committee. I know it's getting late. I know you're tired. We're all tired. I'm not going to take too much time, but I do want to thank everybody that I had a chance to work with through the long process of getting to where we are today. I want to thank you all for hearing this. I genuinely think it's rare that we have an opportunity to have bills like this, right? Where you do have, like you said, a kumbaya affiliation or where you fall on the spectrum, people can understand it's important. So I am very, very thankful for people coming up today and testifying about the importance of this. It's also very rare that we have a chance, I think, to make a really positive impact on people's lives in a really tangible way in a pretty simple manner. Like Sarah Howard said, there's two things essentially we're implementing with this going into effect that don't currently exist. Or they do exist, but they're not getting reimbursed for. They may seem small, but to the moms who actually take advantage of those programs, they will be huge and they will have a massive impact both on their health and the health of their baby. And again, I can't reiterate enough the cost savings that we see over a long period of time. Once we're done with today's hearing, I'm happy to sit down with folks and talk a little bit more about the Colorado program and how they saw that cost savings, but they really do go into great detail looking at individual cases and on a macro level, the amount of cost savings that you see even in the first year by virtue of providing these services. I think a lot of times when we talk about prenatal care, we talk about what are the medical aspects of it that we can do to address the problems after they've already occurred. I think what this seeks to do is to be a part of the broader solution where we do upstream investments to actually stop those issues from happening in the first place. It's not just the medical side of things. It's the socioeconomic factors. It's the nutrition. It's the having somebody to help direct you where you need to go. And if we do that, if we make that investment, I think we're going to see big returns both financially, but most importantly for moms and for babies. So I would appreciate your support for LB 857, and I'm happy to answer any questions you might have.
Are there any questions from the committee? Seeing none. Thank you very much.
Thank you.
All right, well, that'll close our hearing on LB 857. We'll now open up the hearing on LB 1355, and welcome Senator Vargas.
Okay. Hello, everyone.
Welcome.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. And my name is Tony Vargas, Tony Vargas. I represent District 7, which includes the communities of downtown and South Omaha. I'm here to introduce LB 1355. I appreciate your time as well. I know it's been a later day maybe than what you expected. I'm here to introduce LB 1355, which will make critical updates to the Opioid Recovery Fund to address the serious public health crisis stemming from the rapid increase in the use of prescription and non-prescription opioid drugs by establishing aid programming. I brought this legislation to streamline getting funds out to the community and out into high needs areas. And the Opioid Remediation Advisory Committee is actually constituted to provide recommendations for the use of monies from the Opioid Recovery Fund. And these aid programs are based on many of those recommendations. It's the intent of the legislature in this bill to appropriate $4 million annually from the Nebraska Opioid Recovery Fund, beginning in FY 24 to 25, for grants for aid programming under the Opioid Prevention and Treatment Act, with each aid program receiving a minimum of $500,000 in grants. The aid programs will be created by local public health departments, state patrol, healthcare facilities, and the behavioral health regions to meet a variety of needs in response to the opioid epidemic. And the Department of Health and Human Services will oversee, decide, and administer these programs. In 2022, 175 Nebraskans died of a drug overdose. Of those 175 deaths, 60% of the cases had at least one potential opportunity for intervention. The statistic stands out to me when we truly think about the human cost of not getting these dollars out. In the United States, 81.8% of all overdose deaths involved at least one opioid. In Nebraska, 67% of all overdose deaths involved opioids. 67%. Illegally made fentanyl was the top opioid involved in both cases. What I handed out to you are two things. A one-pager about this bill, actually showing you the delineation between the different aid programs, but it also included a separate is an amendment that we've been working on. We've had conversations with a couple different groups in preparation from this to make sure that not only were the funds being allocated, and also not only that the DHHS would be administering the funds, but also making sure that some funds were going to behavioral health regions. And so that amendment is made to make this bill better and improved. So that is the most updated amendment that I'm asking you to consider. And that's the major change that you will see in this legislation. So with that, I'm happy to answer any more questions. There are also going to be folks behind me who will speak further on not only on the work that the Opioid Remediation Advisory Committee and other people that do this work across the state. So if you have some more substantive questions about what is or is not being done and the need for getting these funds out sooner and quicker, you can ask them. Thank you.
Thank you. Are there any questions from the committee? Don't see any yet, so I'm assuming you're staying to close then.
Yeah, I'm sticking around.
All right.
We finished an appropriation, so I'll definitely.
Oh, all right. Well, we will take our first testify in support of LB 1355.
Good afternoon, Chairman Hansen, Health and Human Services Committee members. I'll be brief, and I've got a long afternoon. My name is Jeremy Eshelman, JEREMYESCHLIMAN. I'm Health Director at Two Rivers Public Health Department in Kearney. We represent the jurisdiction of Buffalo, Dawson, Franklin, Jasper, Kearney, Harlan, and Phelps County, serving nearly 100,000 constituents. I'm here today on behalf of Nebraska Association of Local Health Directors to testify in support of LB 1355. As Senator Vargas mentioned, LB 1355 would allocate funding from the Nebraska Opioid Recovery Fund to local public health departments, law enforcement, health facilities to address the continuing community repercussions of opioid abuse. I want to thank Senator Vargas for introducing this legislation. As Senator Vargas had mentioned, the opioid epidemic in Nebraska is a serious public health crisis stemming from the rapid increase in the use of prescription and non-prescription opioid drugs. I have a personal story I'm not going to share now, but if anyone's interested, I can tell you later. This is very near and dear to my heart. I've had family that's been affected by opioids, and it's just like a lot of other illicit drugs. It's a very damaging thing. So I'm going to skip over some of what I have in there as far as data. Senator Vargas had discussed that, and you can read some of the data that's in there too. But through the public health surveillance system, we continue to improve our understanding of how substance use and overdose deaths are affecting our communities. And in particular, this investment in local public health will allow rapid community engagement to address the fundamental effects of opioid abuse. As an example, some work that we've done in the Two Rivers Public Health Jurisdiction involved public health staff visiting local pharmacies, schools, first responders, licensed liquor establishments. This was elevated by our national association, the National Association of County and City Health Officials, as a promising practice award in 2023. And just to give you an idea, we're one of 30 out of like 3,000 health departments in the United States. So it's something that's very prestigious, and it's just highlighting best practices across the United States. So investment in work in local public health across Nebraska, and it does include evidence-informed prevention activities such as promotion and distribution of naloxone, Narcan, drug deactivation bags, promotion of drug take-back programs. And when these resources are in place, our communities are safer. That's just a proven fact. So just to wrap up, local health directors support LB 1355 as it allocate funding from the state Nebraska Opioid Recovery Fund to fund local public health departments, law enforcement, health facilities to continue to address the damaging effects of opioid abuse that's happening in our communities. So, and this really will help us continue to have effect on this problem. So otherwise I'll stop there and thank you. And thank you for your time today, and ask if you have any questions.
All right. Are there any questions from the committee? There are none. Thank you very much. Appreciate it. We'll welcome our next testifier in support.
Good afternoon, Chairman Hansen and the committee. My name is Jamie Bland, Jaime Bland, and I'm President and CEO of Sync Health, which is Nebraska's designated health information exchange and administrator of the PDMP, the Prescription Drug Monitoring Program. I'm here in support of LB 1355 as it provides for grant funding to local public health departments and healthcare facilities for programs that include data tracking related to the opioid epidemic. As the administrator of the PDMP, Sync Health has seen firsthand the power of data at work in addressing the opioid epidemic in Nebraska. Nebraska has required the reporting of all dispensed medications to the PDMP since 2018, including any controlled substances dispensed by veterinarians, and was the first in the country to do so. Additionally, all covered providers are required to check the PDMP before adjusting the dosage amount of prescribing Schedule II drug to a Medicaid client. It's seemingly simple framework. Collect all the dispensed medication in a consistent and accurate way and make the data easily available for prescribers to engage with it as part of the treatment and prescription decision-making process. This simple example of consistent data and use has benefited Nebraska immensely. Over the history of the PDMP, we've seen positive reaction to the dispensing habits of providers in the state. Through the use of PDMP in coordination with DHHS, along with local and regional medical associations and schools, we've seen gradual decrease in the prescribing of opioid medications. As we look at the PDMP statistics, we can see that we've achieved a level where practitioners believe patients are well cared for while maintaining appropriate levels of vigilance for this class of medication. Nebraska continues to gain immense value from this type of data tracking because, one, we can identify in the data where attention or intervention might be needed, and then two, we can see if all those interventions or changes that were put into place are having any concrete impact. All of this is a testament to the fact that the data work doesn't always have to be groundbreaking or innovative. It just has to be meaningful and reliable, and it has to be happening. With resources like the funding provided for this bill, Healthcare providers and public health departments can include data in their projects to ensure efforts and actions are effective and impactful. Sync Health is supportive of all the grant purposes listed in the bill for the healthcare providers and public health departments, but we're especially glad to see that this bill recognizes the crucial role that data plays in addressing public health and the opioid use disorder. I'd be happy to take any questions.
Thank you. Any questions? Seeing none, you got off easy today.
Good. I was wondering if I get my annual Kavanaugh
Of
artwork.
course you do. Sorry, we have a tradition.
Very good. The next proponent, LB 1355. Welcome.
Thank you. Put my eyeballs on really quick. All right. Good afternoon, Chair Hansen, in his absence, and esteemed members of the Health and Human Services Committee. I also want to extend my gratitude to Senator Vargas for his attention to this crucial issue. My name is Chris Allende, that's CHRISALLENDE, and I serve as a Training and Technical Assistance Coordinator for the Wellbeing Initiative, an organization committed to empowering individuals facing mental health and substance use challenges to realize their fullest potential, find purpose, and foster community. Additionally, I represent the Nebraska Association of Behavioral Health Organizations, NABHO, which comprises 58 organizations statewide, including community behavioral health providers, hospitals, regional behavioral health authorities, and consumers. Through NABHO, we strive to raise awareness and forge alliances that bolster access to behavioral health care for all residents across our state. As someone who has journeyed through long-term recovery from substance use challenges, I intimately understand the paramount importance of accessing timely and adequate care. It is with this firsthand knowledge that I stand before you today in staunch support of LB 1355 and the establishment of aid programs integral to the Opioid Recovery Fund. The Wellbeing Initiative boasts a diverse array of programs designed to bolster support for individuals grappling with substance use challenges. Through our efforts, we have witnessed the transformative impact that aid programs can wield, significantly amplifying our community's capacity to save lives. Recently, we sought funding totaling $500,000 to further expand our programming for substance use disorders, or SUDs, in addition to the critical role of training the public on life-saving measures such as naloxone administration and harm reduction strategies. The addition of 2 wellness coordinators to our team would significantly enhance our ability to provide immediate and accessible support to individuals affected by opioid use and substance use disorders across the state. These wellness coordinators would serve as frontline advocates, offering real-time, low-barrier support to individuals in need. Their presence in communities will ensure that individuals grappling with substance use challenges have access to the compassionate assistance and guidance, thereby reducing barriers to seeking help and increasing the likelihood of successful long-term recovery. Furthermore, the allocation of funding will enable us to hire a nurse who would play a pivotal role in providing direct care community members affected by substance use disorders. The nurse would not only deliver essential medical interventions, but also implement comprehensive assessments and evidence-based harm reduction models aimed at saving lives and promoting holistic wellness. In essence, the addition of wellness coordinators and dedicated nurse to our team represents a multifaceted approach to addressing the opioid crisis and supporting individuals and families affected by substance use disorders. Securing this funding would profoundly alter the treatment and prevention landscape for opioid use disorders. In light of these compelling reasons, I implore you to cast your vote in favor and move forward LB 1355. Thank you for your attention and consideration.
Thank you.
Questions? Thank you.
Questions?
I got off easy too.
I'm not seeing it. Thank you.
Thank you.
Next proponent, LB 1355. Hello.
Hello, members of the Health and Human Services Committee. I am Dr. Ann Anderson-Berry, ANNANDERSON-BERRY. I'm a faculty member of UNMC and a member of the State of Nebraska Opioid Advisory Committee. However, I am not speaking as a representative of the university or the committee today. I am here speaking as an individual. I'm here testifying with regards to LB 1355. The opioid epidemic has wreaked havoc on the United States, and Nebraska has not been spared from the impact of this deadly and ruinous epidemic. Our citizens, from our newborn babies and their mothers to teens dying at their first high school party, to adults who have struggled with addiction for decades, all suffer the consequences of the greed-driven pharmaceutical companies flooding our towns with addictive opioids. In my practice as a neonatologist, I care for infants born with serious withdrawal symptoms requiring extended hospitalization for treatment. I perform NIH-funded research to develop the best interventions to care for these infants to minimize the impact of this exposure and allow hospital discharge. My colleagues and I approach the care of this population in an evidence-based, systematic manner, evaluating all the options for improving hospital care and outcomes while minimizing pain and suffering of the mother and infant. When I was asked by the Attorney General to serve on the Nebraska Opioid Advisory Committee and was elected to the executive committee of that group as co-chair of the Needs Assessment Committee, I expected an approach to the state's program that would be systematic, evidence-based, and would coordinate and augment existing resources. A comprehensive needs assessment would guide our work. Funds would then be used to amplify current programs to prevent and treat opioid addiction and help those suffering with substance use disorder. I anticipated that funds likely would be needed to improve resources to support those dealing with repercussions of the epidemic. Individuals in public service, such as law enforcement, fire, emergency medical technicians, corrections facilities, mental health addiction specialists, and other healthcare workers, would get resources to optimize systems and services for Nebraskans. In the summer of 2023, the committee authorized an RFP for a needs assessment, subsequently distributed that RFP, received bids, approved a bid through a vote of the committee, and followed a transparent process. Once the request went to the state to sign the contract and release the funds, we were informed that the state would not be approving a needs assessment and had their own plans for the funds, delaying funds release for a year and a half into this process. Our RFP for opioid addiction prevention grants were also halted. Our next meeting is February 28th, at which point we hope to learn more about how DHHS will be spending the money now that it is clear that the advisory committee's input is not needed. After working on this committee innumerable hours over the last year and a half, no statewide funds have been dispersed through the committee. At present, this committee is awaiting for further updates on how opioid settlement funds will be spent from DHHS, as it is clear they see no role for committee input. Other states across the nation have also maneuvered to integrate these funds into their general operating budgets by pulling block funding for existing opioid prevention and treatment work. While this approach may meet the letter of the agreement for use of the funds, I would argue that it doesn't meet the intent nor my expectation of how we could do better with our resources in Nebraska to impact this deadly disease. Senator Vargas described his bill, so I'm going to skip to that paragraph, and I'll urge you to consider LB 1355 as an alternative to the current state of distribution and use of Nebraska's opioid settlement funds. It is critical that there is transparency and accountability to the people of Nebraska in the use of these dollars to develop resources to mitigate the impact of the opioid epidemic on Nebraskans. Short of a comprehensive needs assessment and statewide coordination in prevention and treatment efforts, this bill provides an acceptable alternative for use of these funds. We must demand accounting of every dollar that in the current state as prescribed by DHHS interim leadership in December 23 does not guarantee this. Thank you, Senator Vargas, for introducing this bill. I'm happy to take any questions.
Dr. Anderson-Berry, that's the fastest I've ever heard you read anything, and it's very impressive.
I am fired up about this process, let's just say.
Despite the speed, tell me a little bit about that piece of nothing being dispersed from last year.
We were assembled by the Attorney General and had very minimal direction from his office about operating procedures. And so we formed an executive committee with a chair, held regular meetings, monthly meetings with a committee that was representative of the entire state. We had people from Omaha, Lincoln, all the way out to very western Nebraska, Valentine, small towns, large towns, physicians, people who had suffered from substance use disorder, law enforcement, firefighters. It is a wonderful representative committee. We came intentfully to do this work, worked hard, dedicated our own and devoted our own personal time and efforts to do this. And then about a little less than a year into the process, we were told that everything we had done did not meet open meetings requirements, of which we'd had no guidance on, and we had to strike everything that we had done from the record and start over again. And so then we started over again. People are having to drive 8 hours to come to in-person meetings to meet open records requirements and get quorum. And we worked hard as a committee, and we did that. And we redid all of the initial work we did with passing bylaws and reelecting the executive committee and the co-chairs. And then we worked incredibly hard to write an RFP that would allow for a needs assessment that was complementary to data that already existed in the state, but that was comprehensive across multiple sectors. And we set out an open call with a budget and expectations. We reviewed multiple proposals as a committee, again, all on our own time, and made a presentation to the full committee with our recommendations for what the best proposals were that would meet the needs of Nebraska citizens. We had an excellent proposal, moved that forward. We were ready to accept that and issue a contract. And then we were told that we had no authority to issue the RFP, even though we'd worked through DHHS to issue that. And in the interim, we had parallel process moving forward with RFPs for grants for substance use prevention. And so a call went out to the entire state again for groups and individuals to present proposals for very worthy projects that would have been implemented across the state to get this money into the hands of people instead of sitting in an account in DHHS, which is where it is right now. And we were also told after we got dozens of phenomenal proposals that we had to inform them that we had no authority to ask for an RFP for proposals for grants, and that process would also be halted, and that they could go to their behavioral health districts and ask for money if they thought that their project was worthy. We found that all of this out at our December 2023 meeting, and we meet again, as I mentioned, in February of 24. So I'm very interested to hear what the interim director has to say to us this month. But as it sits now, we're not using this money to help the people that need it. And I am not confident that every penny will be accounted for if we don't do something like Senator Vargas's bill. It is abhorrent to me that the Attorney General would have this entire process, which was supposed to be transparent and involve all stakeholders. And then we're told after years of work that we have no authority and what we've done doesn't matter.
Sounds frustrating.
Well, it's not so much frustrating for me. It should be frustrating for the citizens of Nebraska. Their mothers, fathers, infants, brothers, sons. This epidemic impacts everyone of every socioeconomic status and of every zip code. We should all be furious that this money isn't hard at work for Nebraska citizens this minute.
You sit in a somewhat unique seat, so there have been some statistics here. Comment on the last 4 years or so for us. What are you seeing in terms of the usage, the problems? Give us a flavor.
In my personal practice, these infants are escalating. I had 2 yesterday. I discharged one. I admitted another one today. And that's one hospital, one practice, right? I do a lot of research in this area, and I had a study 6 years ago. We were open for 4 months, and I enrolled 3 babies. I'm opening the next study next month. And as I said, 2 babies yesterday, 2 babies today, 6 babies last month. It is escalating exponentially. And these babies are sick. Their moms are devastated. You know, you cannot point any finger at a person that has substance use disorder because the system is set up against them. It is not a weakness. It is just a matter of living in our society today and whether or not you got hit, right? Like, don't point fingers at these people. Let's help them and let's get to prevention so that we don't have to have babies in the hospital for 4 months because they need medication for their substance use withdrawal.
Thank you. Other questions? Senator Kavanaugh.
Thank you. Thank you so much, Dr. Anderson-Berry, for all of your work everywhere, all of the time. When were you appointed to the committee?
Oh, yikes. I was one of the original members, but I don't remember the
2020,
exact
I think,
date.
is when the original legislation was enacted, so
Yeah,
2020,
shortly
21. So when you say we were told, were you told by the Attorney General's office or were you told by the Department of Health and Human Services?
We were told by Interim Director Tony Green, who I believe is here in the room today. So maybe you can ask him a little bit more about it.
Okay, so in all of the different iterations that you spoke of, those directions came from DHHS.
Those directions initially were coming from the Attorney General's office.
Okay.
Or a representative of
And
of
under
that
the
office.
previous Attorney General.
Under the previous and current Attorney
And
General.
current Attorney General. So who told you you were violating Open Meetings Act?
Actually, that was Lynn Rex who came in and said, hey.
From the League of Municipalities?
Yes.
She came and told you that you were violating open meetings. In what capacity?
Yeah.
And what authority?
I think the municipalities have a vested interest in how these funds are spent, and she had engaged in monitoring the process. I don't want to speak for her, but it was through her that I first understood that we were violating open meetings rules.
Well, did the Attorney General agree that you were violating Open Meetings Act? And I say this as a person who very transparently loves transparency, and I love me some Open Meetings Acts, but I am confused as to how you were violating them in this particular instance.
We were using hybrid meetings and didn't have an in-person quorum a number of times, the appropriate number of times a year to be considered in accordance with Open Meetings Act. And we also, I think, had some posting issues with our Zooms, and a Zoom was changed to a WebEx 15 minutes before one of the meetings because of a login problem. So there were some issues with the public being able to access those electronic meetings.
Were the electronic meetings purely electronic or were they hybrid?
All our meetings were hybrid that first year.
So they still had access to the meetings, they just didn't have access to the electronic version platform of the meetings. Okay, I'm not an attorney, but this is.
Nor am I.
Seems.
I don't do any of that attorney stuff.
Okay, so is Ms. Rex a part of the committee?
She is not.
So she brought it to the attention of the committee that you were in violation?
Mhm.
And then what did the committee then go to the?
The committee consulted with a representative from the Attorney General's office. We took a pause, met as executive committee, rewrote bylaws, took a different approach, reset expectations for attendance.
Did the Attorney General's office agree that you were in violation?
I believe that they did. Yes. Again, I don't want to speak for anyone else, but it's my understanding.
But did they communicate? They should have communicated. They're very good at issuing opinions. Did they give you
They
right or
then,
wrong?
they then agreed that we needed to redo all of our work for the year. The Attorney General's office
Okay.
did. Yes.
So you redid all of your work still under the Attorney General.
Yes.
And at that point, after you redid all of your work, is when DHHS said you still weren't in compliance? Or you
That's when
didn't-
DHHS said.
You didn't have the authority?
Said that we don't have the authority to do the RFPs and ask for contracts, and that they were going to be determining the use of the funds, and they would let us know how that was going to proceed further in February.
And was DHHS aware that this committee existed and was doing this work over the last couple of years?
Yes, we had regular interactions with DHHS at every meeting.
And they waited until you completed the second round of doing this to tell you that you didn't have the authority to do this?
There was a change in leadership. I can't speak for why the timing was what it was.
But it did happen. They were a part of it for
Every single
plus years, and then they. Okay. I'm exhausted. I don't know about all you. Okay, thank you.
You're welcome.
Sincerely, thank you.
Just have a quick
Yep, Senator
Thank
Walls.
you. Thanks for being here today. The bill calls for $4 million annually to 3 sectors. do you recall, was there an amount of money when you first were asked to be on this committee? It says after the assessment, funds would then be used to, was it the same amount of money? Is it a different amount?
This is a different amount of money than what the committee anticipated that we would have advisory control over. The monies will come in over 18 years. So we don't have the entire pot of money, and they're very convoluted contracts with each individual pharmaceutical company that has a settlement with the state of Nebraska. And so some are heavier on disbursement at the beginning of their contracts, some are even, some are shorter contracts, some are longer. But to my latest knowledge, all of the funds will be collected by the state in over a total of about 18 years. There's also a very complex disbursement formula for behavioral health districts. They get their money off the top, and then the state would have money that was that we anticipated as committee would be spent on broader state programs that would encompass larger projects that could impact individuals across the state. But we felt that we needed a needs assessment first, and so that's why we issued that RFP before we jumped in with dispersing a lot of funds. But we did feel, and Commissioner Vargas, I think will be able to speak on that, is that it was necessary to move some funds out since our process had been delayed. We had not, unintended by us, our process had been delayed. And so we decided to issue the RFP for preventative programming grants as well. And so that's why we made that decision ahead of the needs assessment, because we knew we needed prevention, right? We have a problem, you've got to prevent it. And so we felt like that was pretty safe to move forward with that RFP.
Okay, thank you.
Any other questions? Seeing none, thank you.
Thank you.
Take our next testifier in support.
Okay. I was going to say good afternoon, but good evening now. I feel like we've been here a long time. Chairman Hansen and members of the Health and Human Services Committee. My name is Amy Holman, AMYHOLMAN. I am the project coordinator at the Nebraska Pharmacists Association. In my role, I oversee Stop Overdose Nebraska and our statewide Narcan program. Additionally, I have a seat on the Nebraska Opioid Settlement Remediation Advisory Committee. And I will agree, it's been a very frustrating last couple of months on that committee. We have dedicated the past year and a half to ensuring that opioid settlement funds allocated to the state are utilized effectively. Our hope is that LB 1355 would be a step to ensure these funds are used for their intended purpose. LB 1355 plays a pivotal role in facilitating the disbursement of funds to agencies statewide, empowering them to enhance prevention efforts. This includes essential initiatives like statewide education on opioid use disorder, overdose, and naloxone training, along with implementation of harm reduction services. Additionally, the legislation supports opioid treatment and recovery programs, providing crucial assistance to individuals struggling with opioid use disorders within our state. The NPA would respectfully request that the committee advance LB 1355 for further consideration by the full legislation. Thank you for your time today. I'll answer any questions.
Thank you. Are there any questions from the committee? There are none. Thank you.
Thank you.
Anybody else wish to testify in support?
She took my good evening joke.
Oh.
Waiting all afternoon for that one. I'm Ryan Carruthers. Good evening, Chairman Hansen and Health and Human Service Committee members. Ryan Carruthers, RyanCarruthers. I am here today representing Centerpoint as its Chief Clinical Officer. We appear in support of LB 1355. Centerpoint provides a continuum of behavioral health and primary care services in Omaha and Lincoln with the mission to help the people we serve get better sooner for longer. I hold my PhD in counseling studies and am licensed in the state of Nebraska as a licensed mental health practitioner, a licensed alcohol and drug counselor, and a certified peer support specialist. I've been working in the field for almost 19 years and have focused almost exclusively on helping individuals diagnosed with substance use disorders in the state of Nebraska. I'm not going to read all this. A couple of things I do want to focus on. In the last 24 months, within our residential programs here we have 6 total, 2 in Omaha and 4 in Lincoln. We've had to revive 3 people from opioid overdoses using naloxone. Where in the previous 48 years of our existence as an organization, we had never had to use naloxone in a residential program. The reality is that the problem is now. There's a reason why the Sacklers and the other folks that have brought this upon us settled for so much money. And ultimately, these funds were settled to be able to get help into the people that are struggling with opiate and other addictions. And so contained in this bill, there are provisions for specific amounts to be set aside. It has some really good things in it in terms of focusing on naloxone along with safe syringes. Although the bill does use the less desirable term, clean needles, and fentanyl test strips as well, another really important effort. The idea that these funds are not going to be dispersed to the people that are providing services as laid out in the bill. I love to hear that behavioral health was added in as a specific thing as well. Yeah, I have included a copy of my testimony. And my contact information is on there. Any questions?
Thank you. Are there any questions from the committee? There are none. Thank you. Anybody else wishing to testify in support of LB 1355?
Good evening, Mr. Chair and members. Mary Ann Borgeson, Maryann, B as in Bob, Orgeson. I'm a Douglas County Commissioner, and I am also on the Opioid Settlement Committee. But I'm here and speaking on behalf of the Nebraska Association of County Officials and the Nebraska Association of Regional Administrators in support of LB 1355. I worked with Senator Vargas to have the behavioral health regions included in the bill. Because after all, this is what we do. And he was gracious enough to add them to the bill, which we will support. And I agree with everything that everybody has said.
I like your testimony. 6 o'clock at night.
That's right. That's right.
Are there any questions? Yes, Senator Kavanaugh.
Thank you. Thank you, Commissioner Borgeson. It's nice to see
Hi,
you.
Senator.
So you serve on a body that
Yes, ma'am.
is subject to open meetings.
Yes, ma'am.
And I thought this, but I looked it up. We did in fact pass a change to the Open Meetings Act during the pandemic to allow for a hybrid model of meetings. And I believe the county board utilized that.
Correct.
So as an elected official who has participated in open meetings, do you feel like your committee was in violation of open meetings?
I don't, just because I participated in a lot of the hybrid and actually just full Zoom meetings,
Right.
which, again, during the pandemic, we didn't shut down. We did what we had to do and they worked. And
Yes.
again, they were recorded, minutes were taken, all of that. So it was frustrating that, again, that was brought to our attention. But we, as Dr. Berry said, started all over and went back and redid everything that we had done in an open forum. But when you're talking a statewide committee and you're talking commissioners and sheriffs and everybody from across the state, from Scottsbluff to Douglas County, having the ability to do a hybrid, to do a Zoom is much more efficient and costly than in person. But we did get advised that we could hold, we have to have one And that's fine, we'll do that. And we were on a good road. We really were. We got all of what had been questioned as to being the proper process. We had that all redone. And as Dr. Berry said, we put out the RFP for the statewide needs assessment. We also put out funds to the regions to do region assessments.
And you put this out on behalf of the committee, which was on behalf of the Attorney General's
Right.
office. Okay.
Right, and as it was stated, everybody was around the table when this was happening, the votes were taken, records were made on the meetings. And then we decided, I brought forth the prevention piece and said, a lot of the monies that we're talking about or what's being done currently is all kind of after someone has an opioid issue. So let's focus on prevention. And so I personally wrote the RFP for the prevention. I personally did. And we sent it out statewide and we received 37 applications. And this was during a holiday time. And so I was really impressed that we got that many. And so there was 4 of us who reviewed and scored. And then that's when we were told everything was on hold because we can't do that. And so I wasn't able to bring, from the committee's perspective, a recommendation on what of those 37 applications, all 1, 2, 3, 10, 15, I could not bring what the recommendation was because they told us not to. So there's 37 applications that are sitting out there that responded to the prevention RFP that have not been to that next level of being recommended by the committee for funding.
And when were you told that you couldn't make a recommendation?
It was at our last meeting, which was in December.
So at your last meeting in December of 2023,
Mhm.
you were told that you couldn't.
I was told prior to that coming to the meeting not to bring the recommendation. And so we didn't. And then that's when we were told that we had to follow the state procurement process, which was different than how we had been operating, and left a lot of questions as to what is the role of the committee. And again, there's, I think, still to date, I think there's about 7.9 million and something in the fund as we sit here today. And then that's when Senator Vargas introduced LB 1355 as a better way to get this money moved into the proper places for it to get out to address those issues, all the way from prevention to life-saving efforts.
Okay. Is there anything I'm not asking that I should be asking? Let's see, the reporters ask me that all the time, and I'm just coming to realize that I am way behind the ball here on what is going on. So.
No, I think Director Green will provide us at our next meeting what processes or procedures as a committee we should follow, explain the procurement process a little bit better to us, and maybe help us understand what our role is now as the committee. And again, the committee always knew we were just advisory. We understood that, but we did not understand that what we were doing was wrong. I mean, writing an RFP is not easy.
Yeah.
Putting it out, I mean, statewide isn't easy.
Yeah. And this is all volunteer.
Yes. Which I was happy to do because I really truly believed that we should be focusing on prevention because there was so much being done after the fact, which is still important, but the prevention piece was really important. And so that's why we focused on prevention.
Is the Attorney General's office engaged in these meetings and these conversations?
Mhm.
Okay, thank you.
All right, seeing no other questions. Thank you very
Thank you
much.
for all you do.
Thank you.
Oh, and pass that, please.
All right. Anybody else wishing to testify in support? All right, is there anybody wishing to testify in opposition to LB 1355? Is there anybody wishing to testify in neutral capacity?
All right, good evening now, Chairman Hansen and members of the Health and Human Services Committee. Still Maggie Ballard, MAGGIE-BALLARD, here on behalf of Heartland Family Service. Speaking in a neutral capacity on LB 1355, but would like to thank Senator Vargas for introducing the bill. To be clear, we support dispersing grant money from the Nebraska Opioid Recovery Fund. What we want to comment on is what the funds will be used for. Coincidentally, I'm following up Commissioner Borgensen, which is perfect because I want to talk to you about prevention. I did speak with Senator Vargas's office yesterday about some things I'm going to share with you. And so I'm going to share why we're kind of asking for a change or perhaps an amendment. So at this point, we don't see any mention of primary prevention in what is called the Opioid Prevention and Treatment Act. While harm reduction is an important component to reducing overdoses and deaths from overdoses, we would like to see the state invest in practices and strategies that will reduce opioid use and opioid use disorders from happening in the first place. I also want to speak to this committee about what prevention is, because in my 10 years of working in the prevention field, it usually gets looped in with treatment and is widely underfunded. So Senator Dungan mentioned the story of going upstream. If you're not familiar with that story, it's right there for you. In the interest of time, I'm going to keep moving on. But remember, prevention is going upstream and keeping people from falling into it to begin with. Substance abuse prevention, it consists of 6 strategies. I'll let you look over those, what they're called. Under each of these, especially the educational strategy, there are evidence-based programs and processes that have been proven to reduce substance use or delay the age of first use. Delaying the age that someone uses a substance for the first time is instrumental in preventing addiction from occurring. So think of DARE back in the 1990s, except that DARE was not evidence-based and was actually proven to have the adverse effect on youth. The behavioral health regions are equipped to oversee coalitions across Nebraska that apply for funding so that effective strategies can be put into place to keep people from falling into that river. Prevention work is challenging because it's challenging to measure, because while I can tell you how many students I presented to in a classroom or how many kids I had in a group, you can't measure what you prevented from happening because it didn't happen. It was prevented. But it's still essential that we approach the opioid epidemic in this way. I'd be happy to answer any questions.
I think you just ruined part of my childhood.
Sorry. Now, can I respond to that?
Yeah, well, that's a pretty big.
What happened to you? No, I'm just kidding. As far as DARE, keep in mind, most kids don't use drugs or alcohol anyway. And so it's not that having DARE made kids use, it's just that after going through it, there were more kids that used than if there hadn't been them going through it.
Okay, I did not know that.
Part of my childhood too, I get it.
Any questions from the committee? Seeing none, thank you. All right. Anybody else wishing to testify in neutral capacity?
Good evening, Chairman Hansen and members of the Health and Human Service Committee. My name is Tony Green, Tonygreen, and I'm before you as the Interim Director for the Division of Behavioral Health at DHHS. I'm here to testify in a neutral capacity. And I want to make sure that I am testifying to the bill as introduced. I have not been given or seen a copy of an amendment, so I'm not aware of what's in there. The funds for the Opioid Recovery Fund, this bill indicates that we would disperse these to public health departments, local law enforcement, and healthcare facilities. It would allocate $4 million a year with a minimum of $500,000 dispersed to each of these 3 program aid grants. An amount not exceeding 10% of each grant could be used for administrative cost. Per the language of the bill, it's unclear if the remaining $2.5 million not required for the grant programs is at DHHS's discretion to spend. A technical observation is that Section 10, subsection 1 creates a healthcare facility aid program. However, subsection 2 awards funds to the public health aid program and not the healthcare facility program. Secondly, the Opioid Prevention Treatment Act states that the funds shall be spent in accordance with the terms of the national settlement agreements, which require them to be used in all geographic areas of the state. The bill is silent regarding how to comply with this requirement, and it is incumbent upon DHHS to ensure the statewide use to avoid conflict with the opioid settlement agreement. The proposed legislation requires awarding of funds via grant-based model. DBH would need to establish criteria and needs base for a grant award process to assure alignment with applicable procurement statutes and limits. Additionally, the timeframe indicated in the bill is unrealistic to fully implement as outlined. Finally, the bill allocates a portion of the $4 million to local health departments. As a condition of the settlement, local municipalities, counties, and cities already receive 15% of each settlement directly. These funds support local efforts and could be awarded to health departments, law enforcement, and local healthcare facilities if local authorities choose to award to these entities. I'm happy to answer any questions I can.
Thank you. Are there any questions from the committee? Senator Walls.
Okay. All right. Thank you. Thank you, Mr. Green, for being here today.
Sure.
I just want to go back to the original bill that was introduced by Senator Howard in 2020. It required DHHS to send a report to the legislature and the Attorney General's office on what was happening, an update. I don't recall seeing any reports. Do you know offhand? Have we received reports on what's been happening for the last 3 years?
Yes, so we did submit our first report that is available to you all. It has limited activity thus far, so it's not a very large report. But we did comply and submit the initial report.
Just lately?
Yes.
Okay, so nothing in the report states all of the work that had been done when that committee was formed prior to this. None of that, is there anything in the report that talks about all the work that was done by, what's the committee called? Sorry.
You're fine.
What is that committee called? The committee that Mary Ann Borgensen was on, what's the Nebraska Opioid Settlement Remediation Advisory Committee. Does the report say anything about that to the legislature or the Attorney General about all the work that was done? Any recommendations that were made?
Senator, I would have to go back and pull it. I don't have it here with me, and I don't recall how detailed the report was. So I can follow up with you.
Okay.
There you go.
Hi.
Hi.
How are you?
I am good.
You look a little scared.
Hungry.
I'm hungry too. Okay. What happened? So we have this group of volunteer citizens that were asked by Attorney General, oh my gosh, I forgot his name. Not Mike Hildreth, but the previous one. You know him. Peterson, thank you. I was going to say Bruni. It's a long day. Attorney General Peterson appointed this citizen committee back in probably 2021 or late 2020. And you've heard what Dr. Anderson-Berry and Commissioner Ferguson have said. Can you walk me through what happened? Because I'm sure you can appreciate they gave a lot of time. And it seems like they were being given, whether it's true or not, the perception is that they were being given the runaround. And I believe it is the new Director of Child and Family Services who said to always assume the best intent. So I'm trying to assume the best intent. So can you help me understand what's going on?
Happy to. Again, I'll speak to what I know, and I can't really speak to conversations that may have occurred prior to
Are you an attorney?
stepping in. I'm not an attorney. And so when I became the interim director for behavioral health in January of 23, the committee was in that hiatus that they had described, where they had stopped kind of meeting because they were instructed that they were not following Open Meetings Act. So when I came along, they were having meetings of a small group of the members to just redo the bylaws and kind of get that
Can
going.
I pause you there?
You may.
Prior to you becoming the interim director, was the previous director or representative from DHHS participating in these meetings?
Yes.
Okay, go on. Thank you.
And so the committee really, and I may not have the month correct, I'm sure the committee members would, but summer-ish, the committee came back to life, if you will, and reconvened and adopted the new bylaws and kind of began their work again under the new rules and the more formality of the Open Meetings Act. That prompted, I believe, a meeting around September where the committee had made a recommendation to do a needs assessment. And so those minutes come to the department, and we had representatives that were at those meetings from the department to say the committee is recommending this. And so my task was to figure out, okay, now what do I do with this? And so there really is nothing going on behind the curtains to say that we're changing course. Again, I can't speak to what maybe had happened in the past, but as we go forward with trying to implement a recommendation, what I can tell you is that we have to follow the procurement standards with this cash fund that's been established, and the way that it was done through the committee's RFP process. And we did take this back to our legal department to take a look at the actual RFP that Marianne spoke to that was written, and if it was or could be used in our state process. And so it was determined we could not. We needed to follow the very structured procurement statutes that are outlined in expending state funds. And so that was the conversation then at the December meeting where the committee was made aware that we wouldn't be able to, as they anticipated, to bring grant proposals forward and recommend contracts be issued by the department to these entities. Because I think everyone agrees the committee doesn't have an authority to actually write or sign and engage in contracts. That has to be a state function. When that's a state function, it now falls into those procurement laws. So that was the conversation in December, with a commitment to follow up again on could there be a way in looking at that RFP. So that written correspondence was provided back to the committee shortly after the meeting and put on the website for the committee to take a look at. We did give them some of the small windows in the existing statutes that allow contracting to occur outside of that RFP process. As an example, a contract less than $50,000 or to a university or another government entity. Those would be a couple options that the committee could take a look at and explore. Again, I don't know what's in those RFPs that were submitted. At the same time in December, I relayed to the committee that the division would also be bringing forward strategies that we would like to implement with the opioid settlement funds. And that is scheduled to occur at the next meeting, February 28th.
That you'll bring forward the division's intentions, or are these already happening? What's the status?
They would be the division's intentions. They are not happening today.
Okay.
Yes.
I have more questions, but
Sure.
again,
Yep.
Okay.
It's all yours.
Okay, so thank you, first
Mm-hmm.
of all, for going through that. I'm just trying to ask them in the right order. Okay, so we have the money. We've got 7 million approximately, is that right? How much money is in the opioid fund currently?
As you heard, it is a very complex formula that goes all the way till 2038. In total, of all the settlements between now and 2038, it would be roughly $178 million in settlement funds that would be dispersed to Nebraska.
138 million?
78.
78, sorry. Million.
And they change each year. So as you heard, which is true, that each settlement is negotiated independently. And so some go very quickly, like Walmart, which is kind of one and done payment. Others are spread out over many years. And then
The current balance that is sitting with the state is I wrote down 7.9 million.
I would have to go look that up.
Okay. That is sitting, it's been sitting for some time. What's happening with the interest? Is it being accrued into that account? Is it building? I'm getting head nods from behind.
I would assume it is, yes.
phone friends.
So let me explain the funding, because I think, if I can.
Yes, please.
Because it is confusing, and I think sometimes an unfair characterization to the department and the state funds. There's different pots of funds for this opioid fund. So I mentioned in my testimony, each settlement off the top, 15% goes to the local jurisdictions.
Mhm.
That money is already being dispersed locally to be spent.
Yes.
Then the state pots, you have that 85% then that is there with requirements of 50% of that to be used across the geographic areas in the regions. There was a payment out of that state fund made to the regions in the amount of $10 million last June.
Okay.
To each region, in total of $10 million that has not been spent. So I don't say that as a finger pointing thing. I say it as an educational piece that sometimes there's a perception that there is no money being dispersed, and there is. There was 10 million dispersed last June out of that fund
June
to the region.
2023?
June 23.
So, and we have 5 or 6 behavioral health regions? 6. So $60 million was dispersed?
10.
10 total?
10 total.
Okay, so, and that money is now.
And that's on top of the 15
Right.
that already went to local
That
jurisdictions.
10 is now sitting with them to utilize?
Yes,
Okay, and that was dispersed in the last 6 or 7 months?
June of 23.
23, okay.
So
So, and to your knowledge, none of it has been spent?
a very small amount out of one region, and maybe a little bit, but very, very small that it's,
And
I can
when-
honestly, I can say a majority is still waiting to be expended.
Okay. And then the remaining amount is sitting in this fund, and the state has a plan that they're going to share at the end of this month. Be great if they would share it with us as well. What input has the Attorney General's office had in how the state is going to utilize these dollars?
None, other than the oversight to ensure that any funds that are expended comply with the settlement agreements, and that all of the activities are that comport with the Exhibit E, as you would hear people refer to. But into this development of specific strategies, no.
Okay. I have questions about your testimony and the underlying bill.
Okay.
Again, I was just taking a pause. Okay. So this comes at a time where we are having, this seems to be an ongoing process coming from DHHS this year, which is a little bit different than in the past. It seems that the department, and I recognize that you are a representative of the department, so I'm not saying you personally, but the department writ large is wanting the legislature to be extremely prescribed in the legislation that we're introducing this year, which is resulting in some pretty outlandish fiscal notes. And I bring this up in this context because your testimony here says, secondly, the Opioid Prevention and Treatment Act states that funds shall be spent in accordance with the terms of the National Settlement Agreement. This bill is silent regarding how to comply with this agreement. I don't know that it needs to be vocal in how to comply with the agreement. I don't know if we want to get into the business of the legislature being this prescribed in how the agency carries out their duties. And so I guess I put it to you, or you can go back and come back to us. But this is an ongoing theme that we are seeing, is that the state agency is taking things. Are you familiar with Amelia Bedelia books? It feels like Amelia Bedelia, where it's like so literal, it's overly literal, and not using their own judgment as an agency as to how to comply with a federal act. So I don't know. It's sort of a statement question. I don't know if you want to respond to it. You don't have to, but it is a theme that I am noticing, and I thought that struck me as kind of an unusual comment.
So I'll address the comment because they are mine, and I am the
Okay.
representative of the department, and I write this. So the comment is there because it is unknown what the true intent behind this is, right? So there's some questions in this of the grant programs at a minimum of 500,000 to the 3 entities, and again, if it was just the minimum, what happens to the rest? And that could be a reality, right? Who knows? But it's more as an awareness comment that will be the process. So as these 3 entities would be stood up if this passed, there still is going to be a responsibility on the department that perhaps funding requests would be denied because we have to be mindful of the disbursement process. So it's meant as an education piece that if there was an intent to be more equal and fair, we still have to comply with those terms of the settlement.
I got it.
Yeah.
Thank you. I
You're welcome.
appreciate that. And before I get the cane, I'm going to stop talking.
All right. Seeing no other questions from the committee, thank you very much.
You're welcome. Thanks.
Anybody else wishing to testify in neutral capacity? All right, seeing none, we will welcome up Senator Vargas to close on LB 1355 if you wish to do so. And we did have some letters in support. Let's see, make sure I get this right. Yep, we did have 2 letters to the record. Both of them were in support of 1355.
6:30, y'all. Okay. Thank you very much. And a thank you to the people that testified in support, the people that testified neutral, and also Director Green or Interim Director Green. There's just a couple things I wanted to make sure to emphasize. The first is, and I appreciate some of the questions because it is helpful to understand people's perspectives on what's happened up until this point with the committee. But the intent of this bill is neither to say that things should have, well, I think things should have happened already with funds. That is one outcome. But there's a reason why this isn't like an accountability bill. Like this isn't a, let's go back and figure out what happened. This isn't a, let's revamp the committee. This is a, let's make sure that we create structure. And I want you to think about any grant programs you've ever seen in HHS or in other committees that you serve in, which is part of our job is to create the legislative framework to make sure that things are happening. And also to create the framework to make sure that funds that we have, which is most of the work that I do, and we have funds that are available within appropriations, that we give the guidelines, statutory framework and guidelines to make sure they get out. There's also, and people are on different sides of the spectrum here, on how prescriptive we get, right? Some instances we can get very prescriptive. You've seen the language where it tells you exactly what you cannot use the funds for. And then in some instances it gets extremely loose where it's just like the funds are appropriated to DHHS for the purposes of opioid prevention and then there's no other language. We had bills and appropriations even earlier today that were not that they're vague, it's very generalized. The intent of this is to create the framework that will make sure that a set of funds goes out somewhat consistently every year and that align with a lot of the purposes of the settlement agreement language, and that DHHS will determine what those best parameters are for that $4 million so that we can get money out. That's what the intent is. The reason why there's minimums is so that we don't just prescribe a $4 million contract to one thing and instead think about year over year. Maybe there's smaller things that we should be doing in these parameters, but theoretically it means that if they do 500,000 for each of the parameters, it is up to them to decide how they would allocate another $2 million or 2.5, either to one entity or many entities across any of these sort of sub-programs. The point is, I do trust that the agency, in collaboration with the people that you heard speak, they're going to get the dollars out if we provide them this framework and we tell them we want you to get the dollars out, and that there's a clear understanding that there are allowable uses of what this grant program can and cannot do. There is additional language within the settlement agreement, I think what you heard from Interim Director Green, that will make sure that we're not violating any legal issues with the settlement agreement. I did not put that in here because we are required to abide by those regardless. This is to make sure that we can get those funds out in a very discreet and measured manner. There's a reason why we're not saying let's just get all the money out every single year. Theoretically, we can get like another $10-20 million next year. The goal isn't to spend all that money. To your point, there's interest that'll be accrued into this, which is good because if that means that this fund can sustain itself a lot longer, right? So in terms of the flexibility, we intentionally put flexibility into this, not so overly prescriptive, because I believe that DHHS will make decisions in collaboration with people that were here testifying, and we'll get the funds out. That's the intent. I'm happy to work on any other language. What we don't want to do is get so prescriptive where then you're here next year and then the money hasn't gotten out. I appreciate you. I appreciate all the testifiers and support. We'll definitely work on any technical amendments that will enable this program to come into existence and make sure dollars get out, and happy to answer any additional questions.
Thank you. Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thank you, Senator Vargas. First question, on the fiscal note, it says 4 million in general funds. Is it not, this is money that's
Correct.
a
Yes.
specific fund, so should that be cash funds?
It should be, unless the way that they might have assumed that the money was moved to the general fund for the purposes of this. That's my assumption.
But it's not a new 4 million general fund expenditure. It's
no.
just to clarify for the committee
No.
that it is coming out of this existing pot of money for this. Okay. To Director Green's point about and his testimony about the prescriptiveness of it, is the intention for it to be a 4 million one and done? Is it intention to be an ongoing? And there's so many different mechanisms. We can put a trigger that if it gets to a certain level, then a certain percentage has to be spent out, We can do like the tobacco tax where it's a percentage of each penny goes somewhere. So is that something that you would consider doing, or is for this immediate time, we just want to do this right now and future legislatures can address the ongoing idea of this fund?
So we thought about that. And part of the difficult part of this is, and you heard it from many people, it's not easy to predict when funding will come in.
Right.
Which is why I don't think it's fiscally responsible to say we're going to allocate over, like $15 million every single year, because we won't know if there's $15 million. I think it is, that's the right, we have it at this amount because it's a lot easier to predict. And honestly, if there are no funds in that cash fund, the money won't be appropriated. Unlike a general fund obligation, money will continue to be appropriated because it's a general fund obligation in our budget. If there's not money in this cash fund, there will not be money that goes out. It also means that if there is more money, it can't get out. So if the agency, is thinking about other uses for this fund, for these funds over the years, they will still be coming. At least this is my hope. They will come to the Appropriations Committee and let us know where they intend to use these funds so that they ask for a cash fund appropriation and transfer for an allowable use. I don't know what it's going to be, but in the meantime, in not the short term, but I think this is a really good framework, and I think that's what you heard from other individuals, to make sure that they're getting out without putting constraints too much on also DHHS, which I also don't want to do.
I had another question, but I forgot what it is. I think it's that time of night. Sorry.
Nearly 7 o'clock.
Okay. So seeing no other questions, thank you very much.
Thank you.
And now we'll close our hearing for LB 1355. And one more to go. We will now open up LB 1325 and welcome back Senator Vargas to open.
Wonderful. Good afternoon, Chairperson Hanson, members of the Health and Human Service Committee. My name is Tony Vargas, TONY, VARGAS. I represent District 7, which includes the communities of downtown and South Omaha. Here to introduce LB 1325, which would allow pharmacists and retailers to sell fentanyl test strips over the counter to the public. It also allows, but does not require, local public health departments to distribute fentanyl test strips at the local public health department facility without a fee. Fentanyl test strips are inexpensive, effective way to test for the presence of fentanyl, a fentanyl analog or a drug adulterant within a controlled substance. Fentanyl is one of the most common drugs involved in overdose fatalities. Even a small amount can be deadly, and it can't be identified through sight, smell, or taste. It's added to other drugs because of its extreme potency, which makes drugs cheaper, more powerful, more addictive, and more dangerous. Fentanyl test strips provide results within 5 minutes and detect the presence of fentanyl almost 100% of the time. A study involving a community-based FTS distribution program in North Carolina found that 81% of those with access to FTS routinely tested their drugs before use. Those with a positive test result were 5 times more likely to change their drug use behavior to reduce the risk of overdose. Encouraging the use and distribution of these test strips is a cost-effective way to prevent drug overdoses and reduce harm in our communities. I was encouraged to bring this bill after seeing other states' successful bipartisan efforts to enact similar legislation. Though some of these states actually classified these strips as drug paraphernalia, Nebraska has not taken this action and does not consider them to be drug paraphernalia. I'm hopeful that this bill will provide the clarity and clear up any confusion regarding the classification of test strips, and will encourage our public health departments to distribute fentanyl test strips to ultimately reduce the number of drug overdoses and reduce harm in our communities. I'd also like the committee to know I'm open to working on this. I've heard from stakeholders that adjusting the language from fentanyl testing trips to something along the lines of drug checking products to cover a more broad stroke of life-saving products. I'm happy to work on that. Very, very high level. This is something that's worked in other states. This is an allowable use, as you can tell. Nobody's mandated to then provide these test strips, but making sure we allow them to do it in state law will ensure that we are providing the clarity and the authority to do so that isn't already stay laid out in statute right now. So with that, I'm happy to answer your questions and appreciate your time.
Thank you. Are there any questions from the committee? Senator Repeat.
Thank you, Chairman Henson. I guess my one simple question would be is, what's the price point on these things? You know?
Oh, I think I'm trying to remember the amounts.
Something.
I know, I'm trying to, I didn't hand this out actually. Oh, this is a good reminder. This is why it's getting late. I forgot to hand out the sheets, about $1 per test strip.
$1 strip. Fair enough.
From my fellow executive board member, about $1 test strip.
Fair enough, thank you. Thank you, Chairman.
Yeah, I did see that in some of the opposition letters. There was some concern about using taxpayer dollars to pay for strips such as this. So I think that's some kind of, even though, because local public health departments one's giving it out without a fee. So I think it helps kind of knowing how much these actually do cost. So,
yeah.
Thank you. All right, seeing no other questions. Thank you. And we will take our first testifier in support of LB 1325.
Good evening, everybody.
Welcome.
Chairman Hanson, members of the Health and Human Services Committee. My name is Marcia Muting, MARCIA, MUETING. I'm a pharmacist, the CEO of the Nebraska Pharmacists Association, and a registered lobbyist. The Nebraska Pharmacists Association supports LB 1325. Many thanks to Senator Vargas for introducing this bill. The pharmacists in Nebraska were actually very uncertain whether or not providing fentanyl test strips it was considered to be legal, and this bill removes any doubt. I have outlined for you potential benefits of using fentanyl test strips. And I'm happy to enumerate those, but I would prefer to just close by saying there's reasons to use the test strips, and I'm hoping that the committee will advance this bill, and I'm happy to answer any questions.
All right, thank you. Are there any questions from the committee? Are these currently, I don't think they're illegal technically, are they? Or do you still get them through a prescription? Or?
The question was whether they're considered drug paraphernalia or not. And I got curious because I didn't know the answer to how much they cost. But if you go to Amazon, I believe that you can purchase them. There's no fentanyl in the test strips. But whether, I mean, I'm not even smart enough to know what would be considered drug paraphernalia. I'm assuming something that is used to smoke marijuana is considered drug paraphernalia. So I've had lots of pharmacists call me and say, can I sell these? And I didn't know the answer.
Okay.
Because we had heard both.
Okay.
Considered drug paraphernalia, not.
Okay. Thank you.
Sure.
Any other questions? Seeing none. Thank you very much.
You're welcome.
Take our next testifier in support. Welcome.
Thank you. I'm wondering if I might be the last one. Okay, so good afternoon, Chairman Hanson and members of the Health and Human, good evening, Health and Human Services Committee. My name is Laura McDougall, LauraMcDougall, and I'm the Health Director at the Four Corners Health Department in York, serving Butler, Polk, Seward, and York counties. I'm here today on behalf of the Nebraska Association of Local Health Directors to testify in support of LB 1325. LB 1325 would allow local public health departments to distribute the fentanyl test strips at our facilities without a fee, and also allow pharmacies or retailers to sell fentanyl test strips over the counter. We'd like to thank Senator Vargas for introducing the legislation. LB 1325 would create new access to fentanyl test strips for the public and community partners. These test strips are a low-cost method of preventing an unintentional drug overdose and reducing harm to our families and communities. The paper strips can detect the presence of fentanyl in many types of drugs that we're seeing in our communities. This test quickly provides people who use drugs with information about the presence of fentanyl in illicit drug supply so that they're able to take steps to reduce their risk of an overdose. For those with a family member impacted by a substance use disorder, access to test strips would allow families to test drugs that might be brought home. This could prevent unintentional overdose by the family member with substance use disorder. It could also protect other household members, even younger children or pets, who might unintentionally be exposed to pills containing fentanyl. The rubber meets the road in the counties that I serve. My jurisdiction is bisected by Interstate 80 and Highway 81. Illicit drugs are transported using these routes. It's an uncomfortable fact that the methamphetamine and other drugs are present in our communities. Unless you test the drugs with fentanyl test strips, it's nearly impossible to tell if they've been made more dangerous by being laced with fentanyl. Local health directors support LB 1325, which would allow our health departments to support our partners and families in our communities through new points of access to fentanyl test strips. This will play a role in preventing drug overdoses and reducing harm caused by the increasing prevalence of fentanyl and illicit drugs. Thank you for considering the legislation. I'd be happy to answer any questions.
Thank you. Are there any questions from the committee? Seeing none. Thank you. You're maybe almost the last one. Think anybody else wishing to testify in support? Welcome back.
Thank you. My name is Maggie Ballard, Maggie Ballard, here on behalf of Heartland Family Service, and we are in strong support of LB 1325 and appreciate Senator Vargas for bringing this bill forward. I apologize for once again going kind of off script here, but I just want to point to the fact that I'm inundated with this information. I take it for granted. And so I just thought it might be helpful to make sure we were all on the same page about what fentanyl is, how dangerous it is. I provided a few graphics. I know some people prefer that information that way. I also want to jump down to talking about how I first became aware of prescription drug abuse being such a problem. I started working in prescription drug prevention, substance abuse prevention in 2014. That's when I met Senator Sue Crawford and started studying prescription drug abuse and how to make Nebraska's prescription drug monitoring program at that time fully functional. That summer, I attended my first conference where I remember sitting in a session that brought attention to what we considered an alarming number of deaths from overdoses that the United States was experiencing daily. That number brought us to $47,000 per year and 47,000 per year, and 61% of those involved in opioid. And it devastates me to my core that if we had 47,000 per year in 2024, that would be considered a huge improvement. Because as Senator Vargas talked about, like in 2023, drug overdose death rate reached over 112,000. We are now seeing more people die from drug overdoses than we've ever seen from alcohol, which hasn't happened prior to the year 2020. As many of you know, this problem began because of the overprescribing of prescription opioids, and I could literally speak for hours about the opioid epidemic, and feel free to call on me at any time about that. But as you're probably aware, that people's addiction to prescription opioids turn into a desperation for any opioid, including heroin. So then heroin that they were getting was being laced with fentanyl. And today we even see counterfeit pills that are being falsely labeled as Xanax or Adderall, or things that people are getting from a drug dealer or on Snapchat from people that they meet in the mall. We're talking about young people. 2 years ago, we were warning that 3 out of every 10 counterfeit pills contained lethal doses of fentanyl. Today, it's 7 out of every 10 counterfeit pills that contain a lethal dose. So I want to ask you to vote LB 1325 out of committee. I'd also like to respond to what Senator Hansen brought up as being something that people have said in their opposition. The concern about spending taxpayer dollars on these strips. I can't with that argument. The flip side of that argument is saying that it's not those people that are perhaps going to die of an overdose, that they are not worth the $1 for a testing strip that can keep them alive. That's what that reasoning says, and that is shameful.
All right, thank you. Any questions from the committee? Seeing none, thank you. Anybody else wish to testify in support of LB 1325? All right, seeing none. Anybody wishing to testify as an opponent? Anybody wishing to testify in the neutral capacity? All right, seeing none. Senator Vargas, you're welcome to take the stage one more time to close. And we did have some letters to the record. We had 5 proponents and then 5 opponents.
Thank you very, very much. Keep this brief. Ask for your support for this legislation. We did get feedback from some individuals that are in support that want to make sure we just have some clarity of language, which we'll bring to the committee. But as you can see, a part of our job is sometimes to make sure that when we do or do not have clarity on whether or not something can and cannot be allowed, we have a responsibility to look at that kind of language. And so this enabling legislation, which I like to call, will make sure that we can save more lives. And there's a reason why I don't have a lot of people here testifying about the loss of life, because I don't want that to be the reason why you decide to do this, because the statistics should tell enough of the story about this epidemic and what we should be doing proactively to prevent it. And so thank you very, very much for hopefully supporting this bill and for being this is my last bill that I'll be introducing in HHS. So it's very, very also bittersweet. So appreciate you taking the time to hear me out. And it's always been great coming to this committee. And it'll be very sad to not be able to be in front of this committee ever again. So thank you.
On that note, thanks for that.
So,
any other questions for the committee? Seeing none. Thank you, Senator Vargas.
Thank you.
And that will close the hearing for LB 1325 and close the hearing for today.